patients of diabetes 2, multiple risk factors often coexist, which may influence diverse pathological process. Hence, the scope of a coexisting CVD or CKD in type 2 diabetes may be encompass progressive vascular complications of uncontrolled glycemia, diabetic kidney disease, or cardiomyopathy. It influences of coexisting risk factors like hypertension or dyslipidemia and even iatrogenic complications related to the use of medications. Hence, importance of today's webinar, cardio-renal risk management in diabetes by renowned eminent specialists in the subject. So we are very lucky to have Dr. Jagdish Hiremat to start with the first lecture. I will request my our IMA Pune President, Dr. Meenakshi Deshpande, to give welcome address. Welcome, madam. Welcome, sir.
Good afternoon. Good afternoon, sir. Jagdish Hiremat, sir. Good afternoon. Yeah, I'm very glad to have this meeting today in the afternoon. And many people are attending. I hope all who have registered will join. And as Alka had already told us that yes, diabetes is quite vast and it is going on at a rapid speed, spreading all over, Indian population, especially when we check female population, we are finding that this has become a silent killer. And only about 19 to 20% of all the ladies who are really having diabetes come to the doctors, get diagnosed, and then start the treatment well in time before the complications occur. Otherwise, usually many times in our ladies, we see that the ladies come with complications of diabetes rather than initial stages. So this is a very good webinar series which we are having from AstraZeneca. And I would request all the faculties to elaborate on their topics, and back to our secretary, madam, for the further conduction of this. Thank you.
Thank you, Dr. Meenakshi, madam. Now we'll start with the first lecture by Dr. Jagdish Hiremat, sir. It is on managing acute coronary syndrome patient's journey with statin and beta blockers. I'll introduce sir. Actually, sir needs no introduction. And if I start introducing sir, I will take his talk time. So in short, I will just say a few lines of sir's introduction. He is the Chief of Cardiology, Pune Hospital, Director of Cath Lab, Ruby Hall, Pune, and he is a practicing wholesome cardiology since 1989 in Pune. Started coronary angioplasty program in Pune in 1989. Since then, and started preventive lifestyle program in 1995. Huge experience of special flair for echo Doppler studies, especially of neonatal and pediatric age group. Principal investigator of prestigious international trials like CREATE, Renal, Oasis. Teacher of DNB cardiology for past 5 years, and he delivers more than 150 lectures every year on various subjects to varied audiences. He's a DM cardiology with gold medal in 1986 and specialized training in angioplasty in Melbourne, Australia in 1988. His extracurricular, we have gone through the SIRS programs, anchor of orchestra of group of doctors, Let's Act, perform with Amitabh Bachchan in Madhushala, and perform with Nasiruddin Shah and Nana Patekar as anchor, regular radio program on heart awareness for last 3 years, and won prestigious awards of professional excellence and social relevance. Sadhak of SSY. Sir, you have operated my brother-in-law at Noble Hospital, sir. Yeah, he's quite well in 2014, December. Yeah, thank you, sir. Thank you. You can, yeah, yes, sir.
Thanks for the kind words, President, Secretary IME. It is an important forum because basically we are talking of a group of doctors who carry this knowledge to their own fields. So it's not just a focus group of particular specialty. And because in order to cater to such an audience, I modified the topic a little bit. I have said journey of statins in the lipid management of 2022. This topic would be more close to everybody treating. Like I'm sure many of you have asked me this question. I'm so and so years old. My LDL level is so much. My triglyceride. Do I need a statin or do I need a treatment? So I want to make it more user-friendly in the sense all of us should know whether we need a statin or some lipid management techniques. And of course, if there is complications like acute coronary syndrome and other things, diabetes, then what to do is definitely will be covered in this. So reduction of lipids is when, how, and for whom is what we are going to discuss in the next 25 minutes. The level of evidence is best with anatomy. Anatomy is 2 plus 2 is 4, so it doesn't change. Whereas physiology is not so sure. Surgery may vary over a period of change. And medicine or the type of discussion that we are doing now about statin, it's a to be evidence. That means a little weaker evidence. What we said 5 years ago may not hold true today, or things can evolve in the next few years. Epidemiology amongst the medicine branches is worse. And preventive cardiology, of course, or any other preventive branch keeps changing vastly. So we are at medicine as of today to 2022-23. How do we manage lipids is what we shall discuss. Contrary to the popular belief of the low HDL amongst Indians and high triglyceride in Indians, all this has now been changed. We have to focus only LDL, LDL, and LDL. That means LDL has a causal atherosclerosis. That means higher the LDL, higher the chances of blockage. Lower the LDL, lower the chances of blockage. And this has been proved by n number of trials. In them, the LDL levels were managed to a lower level, and their cardiovascular benefits and events were remarkably good. So based on this premise, we know that LDL is the causal factor. We start reducing that. And look at this epidemiological data of USA, right from 1970 onwards. You can see cardiovascular disease of the heart, coronary artery disease, stroke, all are going down in the last 40, 50 years. And that is where statins started their journey here. And because of the advent of statin, there is a clear drop of cardiovascular events. Initially, those days, even aspirin had this promise, but statin certainly, definitely is a far more preventive than aspirin is. And in a quarter of century in this journey of statins, we have been treating LDL cholesterol to lower and lower values. The initial trials of 90s said that high is bad. Then in the late 90s, it was average is not good. Then it said lower is better as time goes by. And in the latest trial, we say lowest is the best. As low you can go on LDL, the better it is. Fortunately, there are no side effects because all of us were born with an LDL level of 30 and 40 or less. So if you reduce the LDL levels to that level, there is no harm done. So if you reduce to that level, can you reduce cardiovascular events? And the answer is yes. So today, one simple mantra or management of lipids is control the LDL. And if you see, half of the Asian patients in lipid-lowering therapy do not achieve the recommended LDL levels. So if you see so many of them, they were not on par, whether it was Philippines, Malaysia, Taiwan, Southeast Asian countries, it was not on par the LDL levels. So at what stage should the treatment be started? It's always asked question. Whereas person is healthy here, subclinical atherosclerosis, and then the clinical atherosclerosis. Here starts the secondary and primary tertiary prevention. It's easy to decide. But here when the patient is healthy, suppose somebody is 35 years old and has an LDL of 140, do we treat him with drugs? The answer is no. Treat him the answer, the arteries are quite normal at the primary prevention level. If there is nothing else and the LDL is more than 190, then only you are supposed to treat. So normal levels of LDL level 130, 140, you are not supposed to treat with medication. However, lipid lowering diet, weight reduction, and other lifestyle changes have to be instituted very early. And they are true for all aspects of life. Health is a top priority, so all of us have to start leading a healthy life. Then comes the decades and years of subclinical change. Somebody for 7-8 years of diabetes, blood pressure, mild atherosclerosis, plaques have started forming. This is the time when you realize that suppose somebody is 10 years of diabetes and has a LDL of 140, it is not a good news for him. So we have to come down below 100 milligrams per cent. And if somebody has already established myocardial infarction or a stroke or something, then of course you have to lower it to even further to 70. So this is how we go, whether it is primary, secondary, or tertiary prevention for that matter. And for that primary prevention, way back in the 90s, trials started. And all these trials are named on this. They are not important trials, so name-wise, but all it says that even if you started with mild doses of statin, there were already benefits seen with these trials. Secondary prevention trials were more aggressive. In the primary prevention, Jupiter was one trial which was very extremely well done with rosuvastatin, and it reaped the benefits. Actually, patients had remarkably low levels of events. In the secondary prevention, that means somebody already has established atherosclerotic cardiovascular disease. You started with the aggressive dose of statins and you brought the levels down. Further, these trials are 4S, lipid, and all other things. And as late as Prove It is also a late trial which is seen. And if you realize that these trials are again indicating to lower the LDL levels. In order to lower the LDL levels, what we have is statins like rosuvastatin, atorvastatin, pitavastatin, and non-statin groups. Fortunately, we hardly use nicotinic acid. All the trials related to nicotinic acid fail. Bile sequentrants we don't use. Fibrates we use for certain triglyceride levels. Cholesterol absorption inhibitor like ezetimibe is used very often, especially in combined with statin. So you block the absorption from the gut, and later on block the absorption prevention, block the synthesis of LDL in the liver. That is what we think. And the latest MAB, that is monoclonal antibodies like evolocumab and arilocumab, they reduce the LDL levels dramatically. So basically we are using these three statins, ezetimibe, fibrates to some extent, and sometimes evolocumab because it is very, very expensive drug. So in this race to control, I think statins are clear winners. They have been with us for more than 30 years, and all of us are using it to best advantage for us, our friends, our families, and also for the patients. So 1 millimole reduction, 1 millimole of LDL is about 38 milligrams. So that much reduction of LDL reduces the risk by about 21%. So if you give a statin and if the LDL levels are reduced, say by 60 milligrams per cent, somebody had LDL of 100 and now he comes down to 40, then a whopping 42% reduction of cardiovascular events is going to take place. So it's all mathematical now. Reduce LDL and get the results. So many of the other things have been tried, but nothing like the high dose statin, which will reduce 50% of the original value. So that is why it was decided that reduce it by 50% of the original, and you can get a remarkable 50% reduction in the cardiovascular event. So the event rate to 100% was very, very low if you reduce the LDL level 50% of the original. Nowadays, we are talking of direct levels rather than the original level, and it's 50%. So European guidelines came up in 2019, and they said, look, if somebody is normal or very low risk, say a few years of diabetes or just a little hypertension or a smoker above the age of 40, 50, we'll give him a target which is friendly about 116 or 100. Then somebody has had an event, atherosclerotic cardiovascular disease, then the LDL level should be 70. Somebody is high risk, then multiple risk factors, multiple myocardial infarctions and other, then you go down to 55. And very, very high risk, that means despite being on good treatment, is getting recurrent event, then you can go down to almost 40 milligrams. The Lipid Association of India has even a stricter goals. They say that extremely high risk you group lower than 30 milligrams. So imagine somebody has a LDL of 60 and even going down to 30 means you have to have high dose of statin to be used. So our levels are higher. I mean, targets are stricter because our levels of coronary artery disease are a little higher and more aggressive. So the effect of statins on the lipids is rosuvastatin 10 milligram, LDL changes very well, HDL slight increase, triglyceride little change. Atorvastatin and these are the two we use, and pitavastatin is almost close to what the atorvastatin effects are. So the most powerful statin is the rosuvastatin, and we have been using it very effectively. A Swedish registry showed that if you use the statin early and get revascularization done, then your overall combined therapy works very well. That means use statin 34% benefit, add revascularization to that, and combine the two, and you will get a remarkable benefit related to cardiovascular outcomes. However, there are always naysayers. No, statins are not good. There are a lot of side effects. Let's say muscular side effects. There'll be cataracts, there'll be muscle symptom, dysglycemia, new onset diabetes, proteinuria, effects on the liver, effects on cognition, neurological complaints, then hemorrhagic stroke. All these were clouded around the statin, but the overall side effect number is so low, maybe less than 2%, that we feel there is a remarkable drug which has given tremendous benefit to our patients, and we should use them more often than not use it. And the only, if at all, I say muscle function symptoms of pain and all are there, but some very rarely you have to withdraw the statin. And liver function, of course, you should check at least once when we start them. But otherwise, they're all no type of side effects. So it's no wonder it's a 1A indication for reduction in LDL and reducing the cardiovascular, improving the cardiovascular therapy. See, things have to change. Now, this kind of road sign, which say that people with mobile phones are crossing in front of you, will change, will come one day. Similarly, all our science keeps changing. And as I said, in medicine, we are in type 2B. So what kind of a statin do you choose is every time we think of. Whereas rosuvastatin, as I said, in Jupiter trial, showed a remarkable 50% reduction in the original, slight increase in the HDL, some reduction in triglyceride, some reduction in HSCR, or not some, good reduction of HSCRP. HSCRP is supposed to be like an ESR, which will show you whether the atherosclerotic process is active or not. So if you reduce that, obviously you are affecting the plaque. See, management of atherosclerosis is not angina management. Giving sublingual nitrate to angina patient is like giving paracetamol to the fever. But managing the plaque is what atherosclerotic management is, and that comes through good doses of statin and supportive medicine so that the plaque modification takes place. Plaque become firmer, stabler, they don't break, they don't cause events, they don't cause myocardial infarction and strokes. So such therapy, disease-modifying therapy, is more important than symptom relief treatment like nitrates and the nico and this. So rosuvastatin to reduce everything like MI stroke death, unstable angina, fatal non-fatal stroke, fatal non-fatal MI, all-cause mortality in CKD, severe events in CKD, everything is reduced once you use reasonable gold dose of rosuvastatin. And the benefits are not because of anti-inflammatory action or the pleiotropic action. They're all related to direct number of LDL that you get as compared to original, or direct number of LDL. So every time, suppose you want to come down from a LDL level of say 120 to 40, 50% reduction will come to about 70, which is not good enough. So you need additional support, and some support like ezetimibe or evolocumab, when they combine together, in fact, is given even far better results. For example, evolocumab is an injection twice a month subcutaneously. Each injection costs about 19,000 rupees. So the cost of therapy per month is 40,000. So there are people who don't respond at all to anything else in which we use, or there are some people who can either afford it or are supported by their organization. Look at the benefit, the remarkable benefit of almost 60% reduction of LDL, which is not seen with anything else. And when combined with another irinotecan, another MAB, that is a PCSK9 inhibitor, remarkable benefit. So combined with statin, the reduction is so great that we have seen LDL values of 10 and 15 we are not worried because it doesn't cause anything wrong. If at all, it's going to have benefit on the patient. So how I look at lipid management is lipid goals in various clinical situations we should know. For example, all normal adults above the age of 40, we should have our LDLs below 100. So suppose somebody is sitting on 110, I would not start a statin. But if somebody is persistently 130, despite good diet exercise, or because you cannot follow diet exercise, I would use a statin, 10 milligrams of rosuvastatin to bring them below 100. If somebody has multiple risk factors but no cardiovascular disease, if LDL levels originally very high, then again we would aim at below 100. If some angioplasty is done, bypass is done, stroke has happened, myocardial infarction happened, CT angiography showed blocks, then it should be below 70 LDL. All high-risk patients below 55. Very, very high risk below 30. So if you have a triglyceride level which is more than 200, if the LDL goal is achieved, but the triglycerides are more than 200, maybe you can start a fish oil or you can start a fibrate in that. And if there is a disease called isolated triglyceridemia, it has nothing to do with atherosclerosis. If the triglyceride, you've seen triglyceride levels of thousands and sometimes 800, these are the people who would develop gallstones, who develop pancreatic stones and pancreatitis. For that prevention, you have to reduce the triglyceride level with the help of the fibrates or the saroglitaz or the Indian version or the high dose of fish oil. So that is the management of statin. So how I calculate anti-lipid therapy, let's say in 2022, I ascertain a goal. Suppose a patient who is 55, has had a myocardial infarction, has had an angioplasty, is a diabetic. I know that his goal is 55. Then what is his LDL level? How much percentage reduction is required? Accordingly, you choose a statin. Think of adding ezetimibe if required. Think of adding the evolocumab if required. Either singly or in combination, bring the LDL level below. Then only you are benefiting the patient by way of prevention. Otherwise, you are just giving it for psychological reasons of the patient and yourself, and then facing a complication once again in a very short time. The highest dose of statin reduces the LDL by 50%. Another reduction will be taken place by ezetimibe. And then it is not possible. New drug has called bempedoic acid. So we have statin, we have ezetimibe, we have bempedoic acid as oral medicine, and evolocumab as injection. So there is enough polypharmacy around which you can use judiciously. First, decide ascertain your goal. LDL goal, if it is reduced to that level, then you are adding benefit to the patient. So we have these statins, ezetimibe, PCSK9 inhibitor, bempedoic acid. All of them can be used in combination or single to bring the LDL levels to the desired level. Suppose somebody cannot tolerate statin, the other three can be combined. PCSK9 very, very expensive. So we'll work on the other side. So there is enough polypharmacy now to look at these things. So if we accept everything that is presented as true, as really true, there will be little hope for advance. So to next time when you invite me for IMA, I might talk a little different. But today, as I say, ascertain your LDL goal, use polypharmacy. Like hypertension, we have multiple drugs. Diabetes, we have multiple drugs. We have heart failure, we have multiple drugs. So in lipids, we have these multiple drugs. Statin is the king. Beyond that, the other for supported. But with this team, we can bring the LDL levels to remarkably low and do much better in atherosclerotic management than what we have been doing so far. Thank you very much. I'll stop here and take some questions.
Thank you, sir. Thank you for your so lucid lecture. Means the flow is, you keep the flow so in such a way that we just get learned by you. It's always it's an experience. So thank you very much, sir. So on behalf of IMA Pune, I will request our President, Madam, Dr. Meenakshi Deshpande, to felicitate you. This is a bouquet for you.
Thank you,
And
Dr.
our observer,
Jagdish Hiremat, sir. That was a wonderful lecture. It was very short and to the point. And we really enjoyed the whole information which you have given us. I think we will better put it into practical application also now. And with
sir,
a
this is the
bouquet
IMA
of flowers
Uparna.
and IMA Uparna, we would like to
Yeah.
felicitate you, sir. And whenever you get an opportunity, please visit us at IMA Pune.
Yes, sir.
Thank you, sir.
Thank you, sir.
Thank you. Bye.
So there is one question. I'll just see. Any role of statins for patient with retinal eye lipid collection? Some centers like PGI start if complications of DM in eye like maculopathy, even with normal lipids.
I really don't. I read it in the chat box. I don't know the
Okay.
answer. But you have Dr. Rajiv Sethi waiting. He will answer
Okay.
that. He's well read. It's not in the guidance, so I won't know.
Okay, sir. Okay, sir. Thank you, sir. Thank you. Thank you very much, sir. Good afternoon and welcome, Dr. Rajiv Sethi, sir. Sir's talk is on 4 pillars of heart failure, the new algorithm in 2022. So I'll introduce sir. Actually, sir we had many programs with the sir. Sir is a gold medalist in MD, General Medicine from Pune University. He has awarded prestigious DP Basu Award for Best Research Paper in CSI, Fellowship in Coronary Interventions from St. Vincent's Hospital, Melbourne, Australia, awarded FESC and FSCAI from USA. Many articles in national and international journals. Currently, is a president of CSI Pune chapter, senior consultant and interventional cardiologist at the Aditya Birla Hospital and Jupiter Hospital, Pune. So, over to you, sir.
Thank you very much, IMA Pune, for giving me the opportunity. Am I audible, madam?
Yes, sir. Yes, sir. Sir,
Good.
yes, sir.
Yeah. So
the voice is coming little from from a distance, like. So you can adjust your thing, like.
Yeah.
Yes, now it's clear, sir. Yes.
Now it's clear.
Yes, sir. Yes, sir.
So I've been asked to speak on heart failure. And actually, if you ask me, it's a very good space to be in nowadays, because in the last 2 years, we have had so many new developments as far as drug therapy is concerned in patients with heart failure, that we are actually able to improve the quality of life as well as reduce the mortality of our patients with heart failure. And last couple of years, we have had 2 important guidelines, both by the European Society as well as the American Society of Cardiology, which have simplified the way we treat patients with heart failure. And I think it is very important and prerogative of IMA Pune that we take up this particular topic so that everybody becomes aware of what the new drugs are, and we can bring it into our clinical practice so that our patients benefit and we help to improve their quality of life. Now, we all know that heart failure is a very prevalent condition. It is associated with very high morbidity and mortality. In fact, 50% of patients with heart failure die within 5 years of diagnosis. And there is a 1 in 5 lifetime risk of developing heart failure in people who are more than 40 years of age. Now, for years, we have been looking at the Western data, but now we have Indian data available with us. And this is the Trivandrum Heart Failure Registry, which was published in the European Journal of Heart Failure, which looked at the clinical presentation.
Sorry, sir, to interrupt you. Your slides are not moving, sir.
And the screen also, small screen.
Sir, can you please make it full screen?
And make it full screen also.
Yeah.
Yeah, because I'm full screen here.
Yeah, no, here it is not full screen. Make it full screen. Just go above, no, that.
Now,
No, it's still not.
Small screen.
I will share again.
Yeah. Yeah, now. Yeah, it's so much only. Yes, sir. Yes, sir. It's okay.
It's better now?
Yeah, better, sir.
So, yeah. So this was the Kerala Heart Failure Registry, which looked at the morbidity, mortality, and clinical presentation of patients with heart failure. And what did we find? That the commonest cause of heart failure in Indians is ischemic heart disease. And the age of presentation is more than 60 years. And you can see lower down, rheumatic heart disease, the incidence has come down drastically to less than 8%, and that is what we see in clinical practice. But you look at the mortality, the 1 year mortality in Indians is close to 30%. That is 3 times more than the Western counterparts. So we need to be more proactive, we need to be more aggressive in treating our patients with heart failure, so that we reduce their mortality further and improve their quality of life. Now, there has been a new universal definition of heart failure. And this universal definition of heart failure is based on the symptoms and or signs of heart failure, which is caused by structural and or functional cardiac abnormality. And for that, you require at least one of the following: either an elevated natriuretic peptide levels, that is NT-proBNP, or you should have some objective evidence of cardiogenic pulmonary or systemic congestion. And there are 4 stages of heart failure which have been identified. Stage A, B, C, and D. Out of these 2 stages are before the heart failure develops, and that is the pre-heart failure, and that is where we need to act more aggressively. That is patients with hypertension, patients with diabetes, patients with ischemic heart disease. We need to treat them more aggressively so that we prevent them from developing heart failure. But what we do in our clinical practice is that we treat more and more patients who are in stage C and stage D who have overt heart failure. Now, this is the diagnostic algorithm of a patient with heart failure. Whenever a patient comes to you in your clinic with signs and symptoms, you suspect that it is heart failure, you should look for the risk factors, you should look for the symptoms and signs, and there are 2 important tests that we do in patients with heart failure to confirm the diagnosis. The first important test is an echocardiogram, and the other is a biomarker, what we call as NT-proBNP. So these are the recommended tests whenever you suspect heart failure. So you will do an echocardiogram. I think echocardiogram is freely available in most of the clinics, most of the hospitals, and it can be done almost immediately, where you can come to know the ejection fraction and you can diagnose whether the patient has heart failure or not. If you're in a situation where you do not have access to an echo, you can ask for a blood test, and the blood test that we do is an NT-proBNP. Besides this, there are other tests like an ECG and X-ray, and certain investigations like urea electrolytes needs to be done in patients with heart failure. But NT-proBNP, or the blood test that is done to diagnose heart failure, is very important, especially in certain situations. It is important for diagnosis of heart failure. So many times we come across patients who come to us with breathlessness. We are not sure whether this breathlessness is because of cardiac or because of lung pathology. And then what do? We ask for an echocardiogram. And if the echocardiogram tells us that the heart function is normal, then probably it is lung pathology. But if you do not have access to an echocardiogram, the other thing that you can do is do an NT-proBNP. So NT-proBNP is important for diagnosis of heart failure. NT-proBNP also tells us the prognosis. It tells us how bad the heart failure is. If it is markedly elevated, it tells us that the prognosis is bad and this patient would require hospitalization and more aggressive therapy. And it is also important to tell us about pre-discharge risk assessment, and it helps us to guide therapy. Now, echocardiogram is the basic investigation in a patient with heart failure. And in echocardiogram, what do we look for? Whenever you send a patient who has suspected heart failure for an echocardiogram, you must look at the ejection fraction, which is mentioned. And based on the ejection fraction, we have 3 subtypes of heart failure which have been identified. Which are these 3 subtypes? One is a patient having an ejection fraction of less than 40%. We call it as heart failure with reduced ejection fraction. The other group of patients is a patient who has heart failure and whose ejection fraction is more than 50%. We call it heart failure with preserved ejection fraction. And in between 40 and 50%, we call it as mildly reduced ejection fraction. So these are the three subtypes of ejection fraction. Now, why is this important? Because there is a difference in pathology, there is a difference in treatment of patients with heart failure. Certain drugs may be helpful in patients whose ejection fraction is low. Certain drugs may not be helpful in patients whose ejection fraction is normal. As far as the pathophysiology of heart failure is concerned, there are 6 independent pathways which are actually acting in patients with heart failure. And we have drugs which are developed to act on these 6 pathways. Which are these pathways? One is sympathetic nervous system. So to counter that, we have beta blockers, renin-angiotensin system. To counter that, we have ACE inhibitors and ARBs, aldosterone antagonism. We have MRAs called aldosterone. Neprilysin inhibition, we have ARNI group of drugs. And now 2 important pathways have been identified. One is SGLT2 receptor inhibition, and the other is the soluble guanide cyclase stimulation. Now for years, so we must have a holistic approach in the management of patients with heart failure. So whenever we have a patient with heart failure, we not only try to reduce mortality, we not only try to reduce his hospitalization, but we also try to improve his symptoms, and we try to improve his quality of life. Now for years, since the time I did my MBBS, there were only 3 classes of drugs which were available to us to treat patients with heart failure. Which were these 3 classes of drugs? These were ACE inhibitors or ARBs, beta blockers, and MRA or mineralocorticoid receptor antagonist. Now there are a lot of trials with these drugs in patients with heart failure, and patients with heart failure have been found to have a reduction in mortality of around 25 to 30% with this class of drugs. So these drugs form the 3 pillars. So for years we have been using these drugs in patients with heart failure, and if you can see the lower column, you can see here there is a beta blocker, there is an ACE inhibitor, and there is an MRI. These are the 3 pillars on which the treatment of heart failure has based over the years. You can see on the left-hand side, digoxin, no longer a pillar. We don't use digoxin very commonly in heart failure because the large trial, the DITCH trial, showed that it actually increased mortality. So very few situations in heart failure we use digoxin. What are these situations where I use digoxin in heart failure? Is when the patient has atrial fibrillation with a fast ventricular rate, or when the patient has resistant heart failure. On the right-hand side, you can see there is a combination of hydrochlorothiazide isosorbide dinitrate molecule, isolazine, which is available with us, which we use in patients with renal dysfunction who have very high serum creatinine, in whom we cannot use an ACE inhibitor. But remember, all patients with heart failure who have more than 40 years of age should have an angiography done. And if there are blocks, we must clear those blocks because that will help to improve the ejection fraction. And they may require an angioplasty or a bypass depending upon the clinical situation. If the patient does not respond to medical therapy, then what is the next step? The next step is CRT or biventricular pacing. We go to pacing, and there are only a few percentage of patients who may actually benefit from pacing. And if the patient does not respond to maximal drug therapy or to pacing, then the option which is left is cardiac transplantation. So this is what has been following over the years. But in spite of this, the mortality in heart failure is very high. You can see that the mortality at the end of 5 years is still 50%. And hence, we have to rely on new drugs. So which are these new drugs that we have today within our armamentarium to treat patients with heart failure? We have ivabradine, which we use to reduce the pulse rate in patients with sinus rhythm. And the other 3 very important drugs which have becoming the new pillars of heart failure are sacubitril valsartan, SGLT2 inhibitors, and a new kid on the block, very Sequet. So sacubitril valsartan or ARNI is the molecule which has been introduced over the last 6 to 7 years. It is a combination of two drugs, an angiotensin receptor blocker and a neprilysin inhibitor. And this molecule helps to reduce vasoconstriction and enhances vasorelaxation. And the largest trial in heart failure, the Paradigm Heart Failure Study, where this particular drug was evaluated in more than 10,000 patients, showed us that when it was compared with enalapril, it was better. There was a 20% reduction in hospitalization of heart failure and mortality up and above shown by enalapril. So robust was the benefit that it was immediately taken up by all the guidelines over the world. Also, one very important benefit of ARNI group of drugs is that it reduces the incidence of sudden cardiac death by 20%, which was not seen earlier with ACE inhibitors or ARBs. And they are relatively safe drugs as compared to an ACE inhibitor. It is better tolerated, less cough, less hyperkalemia, less renal impairment. Only thing, we need to monitor the blood pressure, we need to monitor the electrolytes, we need to monitor the serum creatinine. So you can see all the guidelines, whether it is American, British, Scottish, Indian guidelines have taken up sacubitril valsartan. And what do they recommend? That if you have a patient with heart failure, and if his ejection fraction is less than 40%, you replace the ACE inhibitor with an ARNI if your patient is still symptomatic. But there are so many of our patients who are coming to our OPD who are doing well on ACE inhibitors. Then do we need to actually switch over from an ACE inhibitor to an ARNI in this situation? Well, I would definitely switch over. The reason being that I would provide him 20% more additional benefit of reduction in mortality and of course a reduction in sudden cardiac death. And if in your OPDs you have a patient who comes with heart failure for the first time, you can straight away start the ARNI group of drugs. And it has been found to be beneficial in improving the ejection fraction. Before this, we never had drugs which would significantly improve ejection fraction. But when you start doing the 2D echocardiograms on these patients who have received ARNI, after 3 to 6 months, you see around 5 to 10% improvement in LV ejection fraction, which was not seen earlier. And the other important benefit of these drugs is that they can be started in the ICUs after the patient is stabilized. There are so many of our patients who get admitted in the hospitals with acute heart failure. And once they are stabilized, you can safely start ARNI in this group of individuals, and it has been found to be beneficial. Now, what are the doses available with us? We have 50 milligram, 100 milligram, and 200 milligram doses available with us. And we usually start with 50 milligram twice daily. After 2 to 4 weeks, we step it up to 100 milligram twice daily, and then to 200 milligram twice daily, depending upon how well they are tolerated. Now, the other important new kid on the block in the management of heart failure are the SGLT2 inhibitors. Now, all of you must be aware that SGLT2 inhibitors were actually anti-diabetic drugs, and they were introduced as anti-diabetic drugs, especially beneficial in patients who had atherosclerotic coronary artery disease or LV dysfunction. These are the drugs which are available with us. They act by inhibiting the SGLT2 receptor on the proximal convoluted tubule of the kidneys, thereby causing urinary loss of glucose as well as sodium and water. And they act like diuretics, but they have other very important hemodynamic benefits. What are these benefits? They have metabolic effects. They reduce the body weight by 2 to 4 kgs. They improve the insulin sensitivity. They have cardiovascular benefits. They reduce the blood pressure by 2 to 4 millimeters of mercury. They improve the endothelial function and so on. And very importantly, they are beneficial to the kidneys. They reduce the intraglomerular pressure, the proteinuria, and cause diuresis. So by all these benefits, they have important hemodynamic action. And they differ from the diuretics in that they cause reduction in the interstitial fluid volume as compared to the intravascular volume that you see with diuretics. So there were two important trials in the last 2 years of SGLT2 inhibitors in patients with heart failure and reduced ejection fraction. These were the DAPA heart failure study with dapagliflozin and Emperor reduced study with empagliflozin, where 10 milligram. Remember, the dose is 10 milligram once daily. When they were compared, the results were similar. There was a 30 to 35% reduction in the hospitalization of heart failure as well as death. And they were protective to the kidneys. The eGFR actually improved in patients who were given these drugs. So these drugs, when added in patients of heart failure, remember, they improved the symptoms, reduced the mortality, and to some extent improved the ejection fraction. And they are very tolerated. They hardly have any side effects. Their dose is 10 milligram once daily. Single dose is available 10 milligram once daily. And the other important benefit of these drugs is their benefit is seen irrespective of whether the patient has diabetes or non-diabetes. So you can safely use these drugs even in patient who is a non-diabetic. You should not be concerned about hypoglycemia because that is a side effect which is rarely seen with these drugs, even when you use it in non-diabetic. So it is no longer only a diabetic drug, it is an anti-failure drug. And because of this fourth drug, the SGLT2 inhibitors, now we have 4 evidence-based medical therapies for heart failure. And these 4 therapies are 4 pillars today to treat patients with heart failure. These 4 pillars are beta blockers, ARNI group of drugs, MRA, and SGLT2 inhibitors. And the other important thing is that these drugs start acting immediately after you start them. And that's why we should try to see that our patients are started on these medicines within 4 to 6 weeks of diagnosis, because that is what the benefit has shown. So initiate multiple drugs together, and the priority is to start with a low dose. So you start with a low dose of these drugs and then gradually step up the dose depending upon the blood pressure and depending upon how well they are tolerated. So what do the new guidelines state? The new guidelines, the European as well as American guidelines, have moved away from the prior method of treating heart failure. The prior method was the conventional method in which we used to go in a stepwise manner. So first step was start ACE inhibitor, increase the dose of ACE inhibitor, then add a beta blocker, increase the dose of beta blocker, then add MRA, then go to M. So it would require at least 5 to 6 months before the patient could be on all the 4 drugs, but we are moving away from this. Now what we have is what we call as rapid sequencing. So all of us have 4 pillars available with us, and depending upon the clinical situation, we look at the blood pressure, we look at the serum creatinine, we look at the serum electrolytes, and we decide which drug we should be starting in this patient. So if my patient has low blood pressure, if his blood pressure is 90 systolic, 95 systolic, where I cannot start an ARNI immediately, I will start with an SGLT2 inhibitor and I will start with an MRA. And once the blood pressure improves, then I will add the other drugs. Similarly, if my patient has CKD, if the creatinine is high and I cannot start an MRA, I cannot start a ARNI group of medicines, I will start a beta blocker, I will start an SGLT2 inhibitor, and once the eGFR improves, then I will add the other drugs. So it helps us to put on our clinician's hat and decide, depending upon the clinical situation, depending upon the parameters, which drug to choose in a particular individual. So as far as treatment of heart failure is concerned, there are certain things that we must do. What are these things we must do? we must start our patients on all these 4 pillars of drugs as early as possible. Try to get them on board depending upon the clinical situation within 4 to 6 weeks. And what are the other things which we should consider? We should consider the use of ivabradine in patients who have tachycardia and sinus tachycardia, which is not responding to beta blockers. Add ivabradine. We should look at the serum ferritin levels and look for iron deficiency. And if there is iron deficiency, we should give them IV iron. So there are certain drugs that we should be starting in our patients. So to conclude, introduction and monitoring of 4 foundational therapies is a must in patients with heart failure, and we should see to it that we initiate these drugs in our patients as early as possible. We need to monitor the blood pressure. We need to monitor the serum creatinine, eGFR. We need to monitor the potassium levels, and we must put on a clinician's hat. Depending upon the clinical situation, we can start these 4 drugs as early as possible. So what is important is that we should situate that we start these patients on these disease-modifying drugs. It is very good to treat symptoms, but remember, errors of omission are much greater and much more severe than errors of commission, and we should individualize therapy depending upon the clinical situation. So these are the 4 pillars of heart failure on which the current treatment of patients with heart failure with reduced ejection fraction is based. Thank you very much. And if there are any questions, I'll be more than happy to answer them. Thank you.
Thank you, sir. Thank you. You have elaborated, you've taken the nice lecture, and all the 4 pillars you have described very nicely. And I think it's a very good message for the people, because we are getting day by day very complicated patients with all the complications, and they come at the last stage, and then we don't know what to do. So I think the patients should really improve with this, all the medicines. So thank you very much, sir. On behalf of IMA Pune, sir, I would like to felicitate you with the bouquet, just a digital bouquet, and IMA Pune. I am Dr. Alka Kshirsagar, Secretary IMA Pune, and he's Dr. Nandakishore Mantri. He's an observer for today's webinar, sir, from MMC.
Hello, sir. Thank you very much. Thank you very much, Dr. Mantri.
Thank you, sir. Thank you.
Dr. Raju Sethi, sir, for an excellent lecture. And this is an online series, so we miss meeting you actually.
Yeah.
You can come over to IMA Pune whenever possible.
Yes.
I will.
Yeah.
Thank you. Thank you very
Thank you,
much.
sir, for an excellent talk.
Thank you.
Thank you, sir.
Thank you, sir.
Now we'll be going to the next lecture by Dr. Suhas Erande, sir. Redefining management of type 2 diabetes by SGLT2 inhibitors. So, I'll introduce Dr. Suhas Erande. Welcome, sir, and good afternoon, sir.
Yeah. Madam, let me share my screen, madam. Let me
yes,
share my
yes,
screen.
sir. Yes, sir. You can. Sir, good afternoon and welcome to this webinar. I'm Dr. Alka Kshirsagar. I'm a Pune secretary, and he's Dr. Nandakishore Mantri. He's an observer for today's webinar from MMC. Yes, sir. We can.
Yes,
Sir, you can move the slides so that.
Yes.
Yes. You try it. It's not moving. Please try. Next slide, sir.
Yeah. I am sure you are able to see the full screen.
No. Full screen is seen, but slides are not moving. Sir, please try to.
No. This is only the first slide.
No, you can try, sir. Whether we can see. Yes, sir.
You can.
Thank you, sir. Yeah. So, Dr. Suhas Erande is a MD Medicine, G Diploma Diabetes from Australia, member of American Diabetes Association, member of International Diabetes Federation, honorary physician, Pune Municipal Corporation. Sir is a practicing consultant diabetologist since last 34 years in Pune, Akshaya Hospital and Insulin Pump Center, Pune. Is a faculty of API, RSS, DI, CID, Jericon National Platforms. Written chapters in Medicine Update, API textbook last 3 years, 5 international published references and counting. Scientific committee member, National RSS DI Conference Mumbai, and Diabetes Mitra Award for social work in diabetes awareness in Pune. He has written book chapters and academic articles for physicians at national and international levels. So over to you, sir. Welcome, sir.
Yeah. Should we, madam?
Yes, sir. Yes, sir. Sir, you can start.
So thank you so much for the invitee by the Pune IMA, and thank you so much.
Please zoom it to 100%.
For the kind words of
Sir.
introduction.
Sorry, sir. Sorry to interrupt you. Sir, please zoom your this thing below. There is on left side. You can see that thing so that you can show. It seems right bottom. So right bottom corner.
Okay.
Present it is 78%. So you make it to 100%. Zoom it to 100% from right bottom corner. Your right bottom corner. Can you manage that, sir? Right bottom corner. Yeah.
You see the next slide now?
Yeah. Yes, sir. You can't do that 100% because it is 78%. If you make it a full screen, people are requesting. Right bottom.
Full screen only.
Okay, sir. Okay, sir. Okay, sir. Thank you.
So friends, we have already been initiated on the idea of the SGLT2 inhibitors, the long form of which is sodium glucose linked transporters or sodium glucose co-transporters. And these are present on the proximal convoluted tubules, the SGLT2s. There is another brother which is called as SGLT1, which is dominantly present on the absorbing epithelium of the small intestine, but we are not going to deal with SGLT1 today. We are going to deal only with the SGLT2 receptors, which are expressed in type 2 diabetes. Their function is to reabsorb whatever filtered glucose from the glomerulus back into the renal interstitium and thence into the circulation. So the hyperglycemia, glycosuria, reabsorbed sugar, and hyperglycemia, that vicious cycle is perpetuated. And if we use a SGLT2 inhibitor, this perpetuality is gone, or the virtual vicious cycle is gone. There is more of glycosuria. So thereby that hyperglycemia comes down. So that's the basic tenet of today's discussion. And some of the aspects have been already discussed by the previous experts. Let me focus on diabetes. We are sure that we are exceeding the figures. Whatever I am showing here, these are the figures which were there in the December 2021 International Diabetes Federation World Atlas. And you can see here that as far as we are concerned, Southeast Asia, we are somewhere around 88 million today. In another few years, we will be exceeding 150 million, that is 11.5 crores. And maybe another 2 decades, we will exceed 15.3 crores. That's a 74% increase. I'm promising you, though you can see that I am somebody who is a, let's say, pessimist, but well, I know we are going to exceed by that 74%, we are going to probably exceed that by maybe another 80 or 85%. So we'll easily cross 16 or maybe even 17 crores of figures. So that's something which is very, very bothersome for us. And what are the predicted future trends in diabetes? In between. Okay, so 46.3 million, this is an old figure, 2019. Right now we are 54.7. okay, 0.7. So we are going to we were actually beaten here only, 46.3 to 54.7. even this is only within 2 years. Let me assure you, this is none other than the IDF president, Professor Andrew Bolton. In the IDF World Atlas 2021, in his preface, editorial preface, he has already written that we have not accounted for the pandemic, that is COVID pandemic, as far as 2021 Atlas is concerned. Now, all of you know that Corona has certainly upped or increased the risk of diabetes, probably even the prevalence of diabetes, or maybe people who were on the verge, they got diabetes or they got screened, and that's why they got detected. A lot of reasons. So we are certainly going to overshoot the figures, whatever are projected. So the world figure by 2045, they say that it will be 70 crores, 70. But let me again tell you, Southeast Asia is somewhere where very heavy rise, 74% compared to today's figures. And I have already told you that we are going to certainly exceed those figures. Now, what about glycemic control? Forget about the number of diabetics. What about the glycemic control? The existing diabetics, are we really treating them well? Not really. Only 67%, let's say 33% patients are at a target of A1C less than 7%, which is a ADA, EAD recommended target, or even RSHDI recommended target, because it protects the organs generally by the UKPDS trial proves. Now, what are the fine tuning there? Parameters of fasting plasma group, we have somewhere around 148. 2 hour postprandial, we are somewhere around 220, and HbA1c 8.2. Mind you, large amount of these are based on our own figures. This is Professor Shashank Joshi's trial of this famous STARS trial, which had shown that the control status of our diabetics is not very satisfactory. The ongoing ICMR INDIAB study across more than 20 states of India, that also has concluded similar figures. So a third of the diabetic population is at control. The 2/3 is not. Another important thing, 62.5% of diabetic populations were above the target of postprandial 180, and the ADA targets are already getting exceeded, as you can certainly see. So we have to really worry about that. Now, if we discuss diabetes and if we only mention blood sugar control or glycemic control, then there is no greater fool than us. Don't be insulted by that statement, because when I utter a word diabetics, my friends, we are not only having a risk of organ complications, retinopathy, neuropathy, nephropathy, cardiovascular disease, cerebrovascular disease, sexual dysfunction, various gastrointestinal cancers, depression, whatnot. All these risks are there when I utter a word of diabetes. So it is a broader risk. So we look at cardio, renal, metabolic conditions, as you can see on the screen. So when I utter a word diabetes, I also have to be worried about hypertension, coronary heart disease, heart failure, acute coronary syndromes. I have to also look at chronic kidney disease, hyperkalemia, and along with type 2 diabetes, other metabolic problems. What you can say, what worse? Probably 65 to 75% of our type 2 diabetic, they have hyperlipidemia. If the person is obese or overweight, our 2/3 of diabetic population, type 2 diabetic population, they are either overweight or obese. And a large proportion of them could have a non-alcoholic fatty liver disease or NAFLD. So we have to look at cardio, renal, metabolic problems, not only sugar. And prevalence of heart failure, if we really specify upon, then as I already told you, diabetes is a risk factor for both heart failure as well as for chronic kidney disease. So what is the prevalence of heart failure in patients with kidney failure? So this is a German chronic kidney disease registry, more than 5,000 patients between the age of 18 to 74. eGFR is less than 60, which is a grade 2 or level 2 diabetic or chronic kidney disease, or with an eGFR more than 60 but over proteinuria, which is more than 500. And you know very well that albuminuria, we have different grades. Macroalbuminuria is something which is more than 300 milligrams of albumin per gram of creat. Microalbuminuria is something which is 30 milligram, 30 to 300 milligrams of albumin per gram of creat. So urinary albumin creatinine ratio. Either of that, either reduced eGFR or increased proteinuria, either of that or both of that, they define chronic kidney disease. So this is the self-report and this is the Gothenburg score. That's the German registry score. And this is the on the you have different groups. So this is the eGFR more than 90. This is eGFR between 60 to 89, and then 45 to 95, 59, 30 to 50, 44, and less than 30. And you know very well that this is normal. This is something which is grade 2, then grade 3A and grade 3B, grade 4 and grade 5. That's the, you can say, grade of nephropathy. So either a reduced eGFR or increased proteinuria, both of them can define chronic kidney disease. And you can see here that in patients who already have heart failure, the prevalence of kidney disease is quite significant. You can see that, very, very significant. Now, what is the prevalence of kidney failure in patients who have a heart failure? This is the meta-analysis of 57 studies. More than, as you can easily see, more than 10,76,000 patients investigating chronic kidney disease. And you can see that a third of the patients have chronic kidney disease. This is a meta-analysis of 28 studies, around 50,000 patients investigating the worsening renal function. So 23%, a fourth of the patients have worsening renal function. So this is from the perspective of patients who have heart failure, but the prevalence of kidney failure. So there is a certain, you can say, interaction between a kidney problem and a heart problem. So if you start with a kidney problem, let's say in diabetes, what is the pathophysiological feature? There is a fluid retention, so the preload on the heart is increased. And there is a neurohormonal overactivation, overactive renin, angiotensin, aldosterone system, and that is why you have a vasoconstriction. So not only the preload is increased because of increased fluid retention, but the afterload also is increased because of the vasoconstriction. So the heart failure is invited. Now, if you have started with heart failure, what are the problems which can affect the kidney? Because of hypoperfusion, right? Hypoperfusion, the ejection fraction of heart is less. So there is a renal ischemia. And because there is a congestion, you have a low eGFR. So the patient starts with a kidney problem, invites heart failure, or he starts with a heart failure and gets kidney failure or kidney problem down the line. SGLT2 inhibitors address both. Okay, the previous speaker, Dr. Sethi, has very beautifully explained that SGLT2 inhibitors are something which actually improve the kidney function even in patients of heart failure. So SGLT2 inhibitor cardiovascular outcome trials, which looked at the primary outcome, 3-point major adverse cardiovascular events, cardiovascular direct trial, the relative risk reduction was 14%, 1/4. EMPA-REG trial, every patient in the trial had an established atherosclerotic cardiovascular disease. Canvas trial, 2/3 of the patient in this trial had an established atherosclerotic cardiovascular disease, but they had multiple risk factors. For example, high blood pressure, dyslipidemia, central obesity, smoking, strong family history of cardiovascular disease, etc. And then the DECLARE TB trial, wherein 60% of the patients had multiple risk factors, 40% of the patients had established atherosclerotic cardiovascular disease. So the starting risk was different in different trials, but the hazard ratios or the relative risk reduction of primary 3-point MACE, 14% in EMPA-REG, 14% in Canvas, 7% in DECLARE TB trial. Naturally, the starting risk was low in DECLARE TB, so the relative risk reduction also was relatively low. Simple. Now, what about the reduction of heart failure, hospitalization, and cardiovascular death in different SGLT2 inhibitor trials? Almost similar. So, in EMPA-REG outcome, the relative risk reduction of CV death and heart failure hospitalization was 34%. Canvas program, the same was 22%. And in DECLARE TB, it was 17%. Right? So, there was a good benefit of using SGLT2 inhibitors to reduce the risk of hospitalization for heart failure and cardiovascular death. Now, the trial, DECLARE trial. DECLARE trial establishes the cardiorenal benefits of dapagliflozin in type 2 diabetic patients. DECLARE trial, everybody was diabetic. But as I told you, 40% patients had atherosclerotic cardiovascular disease established. 60% patients had multiple risk factors like strong family history of coronary artery disease, etc. So, heart and renal complications in the form of heart failure and chronic kidney disease are frequent and early and under-recognized in type 2 diabetes because the patient may not have the symptoms. So, you may not really explore for heart failure or chronic kidney disease. And this can result in significant morbidity and mortality. In the DECLARE trial, dapagliflozin demonstrated cardiorenal protection, reduction in the composite of heart failure hospitalization and cardiovascular death by 17%, as I showed you, development or progression of renal disease. So those who had macroalbuminuria, they came back to microalbuminuria or to normoalbuminuria. That is something which is very important, and the relent that also was. So over a period of 4.2 years in a broad risk population of the patients, 17,000 patients, we have observed cardiorenal benefits. We declare dapagliflozin provides some evidence for early cardiorenal event prevention, going even beyond the type 2 diabetes, that is glycemic control. So this is the glycemic control in DECLARE trial. This was the placebo group, which was non-dapagliflozin, and this was the dapagliflozin group. Initial good reduction, and down the line, the HbA1c certainly climbed, but at the end of the study, there was still 0.2% difference in HbA1c between the placebo and dapagliflozin group. Mind you, this is what is called as a glycemic equipoise. So I cannot argue that dapagliflozin, because it controlled the sugar better, that's why the heart failure risk came down. That's why the kidney was better protected. No, even the non-dapagliflozin users, they also had a HbA1c of 8.1, which came down from 8.3 to 8.1. Dapagliflozin gave a HbA1c lowering which was superior, but not that superior that biostatistically you cannot argue that dapagliflozin heart protection is through only glycemic control. It has to be something else. That's the whole issue of glycemic equipoise. It is clear that SGLT2 inhibitors prevent heart failure hospitalization in a broad group of type 2 diabetic patients and reduce major adverse cardiovascular events only in the high-risk patients with ASCVD. So, this is the heart failure hospitalization, and these are the major adverse cardiovascular events. So you can easily see heart failure hospitalization. You look at any trial, IMA, Canvas, DECLARE, wherever. So here is 35% relative risk reduction, 32% relative risk reduction, 22% relative risk reduction. Very good. Multiple risk factors, no established atherosclerotic cardiovascular disease. IMA, as I told you, everybody was established ASCVD. So nobody was multiple risk factors. But Canvas, 35% patients were multiple risk factors. DECLARE, 60% patients were multiple risk factors. And what happened? There still was a benefit of heart failure hospitalization risk reduction of 36%. Look at major adverse cardiovascular events. IMA, everybody had the RDs. Everybody was an established cardiovascular disease. Canvas, only 60% had, and DECLARE only 40% had. So what happened? The relative risk reduction was significant in those who had a higher starting risk. But look at that. Canvas and DECLARE, those patients who had multiple risk factors, there was hardly any significant reduction, let's say. So 0.2 or maybe 1.01. So there's no, you can say, effect on the major adverse cardiovascular. So if the diabetic patient started with a low risk when he entered the randomized control trial, there was no much of benefit of major adverse cardiovascular event reduction. If the patient had a already higher risk, like EMPAREC, everybody had a established heart disease, then certainly the patient got benefit. This is the story of SGLT2 inhibitors for heart failure. This is normal ventricular function, preclinical or pre-heart failure, as Dr. Sethi uttered. Then we have this Canvas trial, Cadence trial, DECLARE TIMI, EMPAREC, Vertice. They were broad trials, okay? They were broad trials, atherosclerotic cardiovascular disease or multiple risk factors, all diabetic patients. Then we had IMPACT-MI or DAPA-MI. And now we had patients who had established heart failure before they enter the trial, DAPA-HA. Deliver heart failure with preserved ejection fraction, emperor preserved, emperor reduced. And then the chief trial, which is canagliflozin in heart failure. So there are some more coming also. So this is something which is a background, and the patient has progressed from pre-heart failure to clinical stage of the disease and detectable cardiac involvement and end stage heart failure. So that's the clinical spectrum, and this is the trial program. DAPA-HF, let us look at that. 4,744 patients. Everybody had a heart failure. So LVF less than 40% within the last 12 months. The biomarker, as Dr. Sethi had already mentioned, elevated NT-proBNP, EGFR more than 30, and stable standard of care treatment, that is the maybe diuretic, beta blockers, or ARNI already going on. And these are the patients, mind you, with diabetes or even without diabetes. That's something which is a feature. One arm, dapagliflozin 10 milligram plus standard of care for diabetes and heart failure. Other arm, no dapagliflozin, but the standard of care was there. And we were looking at composite of cardiovascular death or heart failure hospitalization or an urgent visit to the clinic or emergency department for heart failure. And the secondary endpoints were cardiovascular death, heart failure hospitalization, total heart failure hospitalizations or CV death, changes in the Kansas City cardiomyopathy questionnaire from baseline to 8 months, renal composite, of more than 50% sustained eGFR decline or end-stage renal disease or renal death or death from any cause. And what was the observation? The dapagliflozin users, there was a 26% relative risk reduction of getting heart failure, hospitalization or CV death with the use of dapagliflozin. And this boils down to 4.9% absolute reduction or number needed to treat. You had to treat 21 patients with dapagliflozin over a period of, over a period of around 2 years to save one incidence or one event of either cardiovascular death or worsening of heart failure. Individual components of primary endpoint were significantly reduced with dapagliflozin. So 30% relative risk reduction of worsening of heart failure event, 18% relative risk reduction of cardiovascular death. Very important. Dapagliflozin reduced the secondary endpoints of all-cause death, 17% relative risk reduction. So heart failure hospitalization, relative risk reduction, relative risk came down. All-cause death risk came down. Cardiovascular death risk came down. Looking at comparison of the DAPA heart failure trial and pitting it against the Emperor reduced trial, similar patients, okay, diabetes or non-diabetes, but the ejection fraction was reduced when the patient entered the trial. What are the components which are we comparing? Heart failure hospitalization reduction, 30% reduction in DAPA group, 31% reduction in the Emperor reduced trial. CV death reduction, 18% in DAPA HF, 8% in Emperor reduced. New diabetes, those who had no diabetes or those who were pre-diabetic when they entered the trial, there was a 32% reduction in DAPA HF trial, 14% reduction in Emperor reduced trial. And the Kansas City cardiomyopathy questionnaire calculated at the end of 8 months for DAPA and 52 weeks for, that is 1 year for EMPA. DAPA, the score improved by 6.1, EMPA it improved by 5.8. Now the comparison of newer therapies in heart failure with reduced ejection fraction. Dapagliflozin is the only SGLT2 inhibitor to demonstrate significant mortality reduction. Right? So these are the different trials where this is a SHIFT trial where ivabradine is used, Paradigm HF trial where obviously Dr. Sethi had mentioned that enalapril plus sacubitril versus sacubitril valsartan, that is ARNI was used. DAPA HF trial, this was standard of care versus dapagliflozin, Emperor reduced, empagliflozin was a standard of care. And by standard of care, I mean it is either beta blocker plus mineralocorticoid receptor antagonist plus the ARNI. What was the observation? These are the background therapies, the standard of care for heart failure. And as I told you, RAS blocker, beta blocker, mineralocorticoid receptor antagonist, ARNI, etc. What was the CV death or hospitalization for heart failure hazard ratio? It was 18% reduction, 20% reduction, 25% reduction, 25% reduction. Hospitalization for heart failure, 26%, 21%, 30%, 31%. CV death, 9%, 20%, 18%, and 8%. So you can look at that. So DAPA HF, there was a 18% and 17% reduction in CV death and all-cause mortality. Now SGLT2 inhibitor CVOTs have consistently shown reduction in the renal endpoints. So let it be EMPA, let it be CANVAS, let it be DECLARE. See that impact of SGLT2 inhibitors on the composite of renal outcomes. That is sustained reduction of eGFR by more than 50%, development of end-stage kidney disease or need of dialysis or renal replacement therapy or renal death. So EMPA, 46% relative risk reduction. CANVAS, 40% relative risk reduction. DECLARE, 47% relative risk reduction. So you can see that whatever the trial, whatever the SGLT2 inhibitor, the renal benefits were always seen. Benefits seen in the cardiovascular outcome trials are also present in patients with more advanced CKD. For example, the CREDENCE trial. CREDENCE trial, everybody was diabetic. Everybody had an established kidney disease. In fact, a lot of patients had macroalbuminuria, more than 5,000 milligrams of albumin per day in their urine. So across, you can say kidney disease. What was the observation? The renal endpoints, doubling of serum creatinine, development of end-stage kidney disease, that is eGFR less than 15, need of dialysis or kidney transplant, renal death or CV death. Everywhere you can see the diamond has shifted in favor of canagliflozin, 30% relative risk reduction in the primary composite outcome, 40% in the doubling of serum creatinine, 32% in the development of end-stage kidney disease, 61% for renal death, 22% for cardiovascular death. So everywhere the patients were benefited. Mind you, these were high-risk kidney patients. What about DAPA-CKD? Everybody had a kidney disease. Okay, everybody had a kidney disease. eGFR between 25 to 75. Urinary albumin creatinine ratio more than 200. That is microalbuminuria, or even let's say macroalbuminuria. Stable dose of RAS blocker for at least 4 weeks, and they could be with diabetes or without diabetes. And naturally, type 1s were excluded, polycystic kidney disease excluded, the other nephropathies were excluded, etc. And again, half of the patients were on DAPA, half of the patients were not on DAPA, and 4,304 patients composite sustained eGFR decline more than 50%, ESKD, renal or CV death. These were the primary outcomes. What was the etiology of chronic kidney disease? Okay, we know that chiefly it is diabetes. So diabetic nephropathy, chronic pyelonephritis, renal artery stenosis, ischemic or hypertensive nephropathy, chronic interstitial nephritis, idiopathic or unknown etiology, chronic glomerulonephritis, obstructive nephropathy, and others. So this is the overall population. Okay, investigator reported etiology of chronic kidney disease in DAPA-CKD. So what was the observation? More than half of the patients had diabetic nephropathy, 16% ischemic or hypertensive nephropathy, 16% chronic glomerulonephritis, right? And then the other, you can say, this is the overall population, this is the diabetic population. So in diabetic population, you can see 86.4% patients had diabetic nephropathy. So bulk of the patients had diabetic kidney disease. Whereas in those who had got no diabetes, mind you, DAPA-CKD also included patients who did not have diabetes. So here, ischemic hypertensive nephropathy was around a third, chronic glomerulonephritis was 42.8. Actually, diabetes was not there at all. What was the observation? Primary composite renal endpoints. There was a 39% relative risk reduction. And mind you, the NNT, number needed to treat, was only 19. So, dapagliflozin certainly proved to be nephroprotective. Now, primary composite outcomes depending on whether the patients had type 2 diabetic at baseline. If it was yes, well, the benefits were relatively less for cardiovascular as well as renal endpoints. If the patient did not have diabetes, the diamond shifted more in favor of dapagliflozin use. Urinary albumin creatinine ratio. What was the observation? If the starting was less than 1000, so lesser albuminuria, naturally dapagliflozin helped that kidneys better compared to those who started with a gross albuminuria. You can see that. And then those who started with a lesser eGFR when they were included in the trial, eGFR less than 45, naturally dapagliflozin helped them, but not to the extent where the eGFR was more than 45. So naturally, the patients start with a lower kidney function or higher albuminuria. Dapagliflozin helps them, but not to the extent that the eGFR is good, relatively good, or albuminuria is less. So higher risk, lesser help or lesser protection by dapagliflozin, but protection all the same. Secondary renal specific outcome. Here also the dapagliflozin users had relative risk reduction of 44%. Oh, very appreciable. All-cause mortality, 31% relative risk reduction in the dapagliflozin users. Again, something which is extremely appreciable. So DAPA-CKD, the first dedicated renal outcome trial to assess the efficacy and safety of an SGLT2 inhibitor dapagliflozin in chronic kidney disease patients with diabetes or without diabetes. What was the observation? 39% relative risk reduction for primary composite, which was renal or CV death, 44% relative risk reduction for renal composite, 29% relative risk reduction for the composite of CV death or hospitalization for heart failure, and 31% relative risk reduction of all-cause mortality. DAPA-CKD expands the cardiorenal benefits of DAPA to the patients with CKD outcome. 60% patients had multiple risk factors, diabetic, but everybody has heart LV ejection fraction less than 40% at the end of, at the inclusion of the trial. and eGFR, everybody was more than 30. DAPA CKD, chronic kidney disease patients, either with diabetes or without diabetes, everybody had chronic kidney disease, eGFR between 25 to 75. What were the, you can say, observations? Primary endpoint, heart failure hospitalization, CV death for declare, CV death worsening heart failure for DAPA HF, renal, especially in naturally this is a renal trial, so more than 50% eGFR decline, end-stage kidney disease, renal or cardiovascular disease, that was the endpoint for DAPA CKD. And what were the observations? Everywhere, dapagliflozin offered both cardio protection as well as nephro protection. In DAPA HF and DAPA CKD trials, though the patient did not have diabetes, still their heart failure was, you can say, the risk was reduced. And in DAPA CKD, despite the patients not having diabetes, they still had a nephro protection. What were the likelihoods of adverse events? We know very well that dapagliflozin can give you something which is called as urinary tract infection or genitourinary mycotic infection, a subtle risk of diabetic ketoacidosis, dehydration, electrolyte imbalance, hypoglycemia, and maybe a very little risk of bladder cancers, other malignancies, amputations, coronary gangrene, etc. You can see here that barring this genitourinary infection, okay, 76%, 76 versus 9, rest everything, whatever risk you take, there is no, you can say, plus or minus between DAPA or the non-DAPA group. So the risk was absolutely similar in non-dapagliflozin and dapagliflozin group as far as the other risk factors. So my friends, to summarize, dapagliflozin was as effective in reducing the worsening of heart failure and all-cause mortality in patients with chronic kidney disease who started with an eGFR of less than 60 as in patients without CKD. 29% reduction in the renal outcomes, composite of time to renal death, end-stage renal disease, or 50% decline in eGFR. And this did not reach statistical significance, possibly due to a small number of events and short trial duration. Nevertheless, the magnitude of the effect is similar to that observed in the other SGLT2 trial and was similar in patients without diabetes. Dapagliflozin was well tolerated in patients with or without CKD. I have just now shown you the side effects. Acute kidney injury events were reduced overall in patients receiving DAPA compared to non-DAPA or placebo. These data suggest that after an initial small decline in eGFR, common to any SGLT2 inhibitor, dapagliflozin appears to attenuate the long-term renal decline in patients with heart failure. So, though the patients have heart failure, and though we have seen that heart failure can adversely affect the eGFR and can go for development of chronic kidney disease, certainly SGLT2 inhibitor dapagliflozin protects the kidney and it also protects the heart, as has been explained by the cardiologist previously. So my friend, dapagliflozin, you can start using no larger or very lofty goal. Dapagliflozin is an agent which is good to control blood sugars. Inadvertently, if your patient is obese, centrally obese, it can be helpful to reduce his waist circumference, central obesity. If the patient has dyslipidemia, certainly dapagliflozin can help reduce some amount of dyslipidemia. Pressure drop also will be seen. Dapagliflozin gives you natriuresis, decongestion or aqualuresis. So it can certainly reduce systolic blood pressure by 3 to 5 millimeters of mercury. Dapagliflozin, as I have illustriously shown you, protects the patient against heart failure hospitalization risk, major adverse cardiovascular events. It can help the patients who already have a heart failure, or it can protect the kidney, whether the patient has microalbuminuria, macroalbuminuria, or the patient has a reduced eGFR. It can stop the relentless decline of eGFR. So a true cardio-renal protection, if the patient has that. So my friends, in Marathi, we call it as a gadrachi pungi.
वाजली तर वाजली.
Gadrachi pungi, wazli ta wazli.
वाजली तर वाजली नाही तर
Dapagliflozin use can give
नक्की
you
वाजणार.
cardio-renal protection, or if you don't, if your cardio-renal protection, well, my friends, I thank you so much for your kind listening. Thank you so much.
So, there is one question. Sir, there is one question. Can I ask? Hello, sir. Hello, sir. there is one question for you, sir. There is
Yes,
one
madam.
question for you.
Yeah.
What to do if dapagliflozin causes loose motions? Does it cause?
Now, this is something which is noted extremely infrequently.
Yeah.
The tune with which we use dapagliflozin these days, especially after it has passed its patent and it has become cheap, we are using practically left and right. So the side effect of loose motions, well, yes, it could be there with any anti-diabetic drug, but it is very, very less with dapagliflozin or any SGLT2 inhibitor for that matter. It can happen with a canagliflozin, but the canagliflozin dose has to be not 100 but 300 milligrams, because strong SGLT2 effect also can inhibit the SGLT1, so the intestinal absorption also can be affected by high dose of canagliflozin, but not with dapagliflozin.
Okay, sir. Okay, sir. Thank you. Thank you
Right.
very much, sir. Sir, it was a very nice elaborative lecture, and you have emphasized on that dapagliflozin for cardiorenal risk. It's a very good for the patients as well as for the consultant also. Because up till now we had a lot of problems with the complication, how to treat and what to give to the patient. So this is a very wonder drug. So thank you very much, sir. So on behalf of IMA Pune, sir, तुमचं screen दिसत नाहीये बरोबर.
Oh, really? It's okay. It's okay.
Yeah, this is from IMA Pune, a token of love, and you can come to IMA Pune anytime to.
Certainly, madam.
This.
Certainly.
Yeah, and this is the IMA Pune. He is Dr. Nandakishore Mantri. He's an observer for MMC
Oh, yes.
today.
Hello,
and I am
Dr.
Dr.
Mantri.
Altak Shirsagar,
Namaste,
IMA
namaste.
Pune secretary.
Thank you, sir.
Yes, sir. Thank you, sir. Thank you. Thank you, sir.
Thank you. Thank you so much. Thank you.
Yeah. Thank you. Now the next lecture, madam. Good afternoon and welcome, madam. Dr. Vaishali Deshmukh, madam.
Hello.
Hello. Yes, madam. So, Dr. Vaishali Deshmukh, madam, will be talking on beyond glycemic control, the Renal protective SGL2 inhibitors, dapagliflozin. So, I'll just introduce madam because in very short, she is an assistant professor in endocrinology, Sasun Hospital and BJMC Pune. She is a consultant and head of endocrinology at Dinanath Mangeshkar Hospital and Deshmukh Clinic, Pune. She is invited faculty over 1,000 CMEs, webinars, interviews, and conferences. Founder and secretary, NGO Sphere, Deshmukh Clinic and Research Center. Awards. She's a gold medalist, Proficient Woman Award, Kranti Surya Pratishthan, Adarsha Mahila Puraskar, Jivan Gaurav Puraskar. She's got 26 publications on her name, and she's a mentor and teaching experience of 25 years. Icon Sanofi M. Gurukul. Author of chapters in 5 books and numerous press articles. She's got 63 global phase 2, 3, 4 clinical trials in endocrinology, MBM research, and special interest in mind-body medicine. Yes, neuro behavioral endocrinology in women. Just last month, on 27, she had taken lecture in our UConn conference at Boat Club. Yes, madam?
Yes.
Yes.
I think it was a very interactive session.
Yeah, very interactive. Yeah. It was a physical conference, a hybrid conference rather. So we had a very good interest.
I had an opportunity to be chairperson for your lecture.
Yes, sir.
So thank you, IMA team, and thank you, madam, for that very kind introduction. It's always a homecoming and pleasure to talk on IMA forum. So I'm also thankful to Astra for giving me this opportunity. I'm also glad to share the forum with eminent faculty like Dr. Sethi sir and Dr. Erende sir. So I would begin with this talk of mine with talking about renal protection that dapagliflozin has to offer. I hope my voice is clear and my slides are clear.
Yes, madam.
Okay.
Yes.
So we heard Dr. Erende sir telling us about the burden of the cardiorenal disease, but in short, I would like to tell you all that the dynamics of heart and kidney are disturbed in diabetes. Why they're disturbed? Because the energy energetics of the cells of these two organs is already disturbed because of glucose metabolism. There is an element of hypervolemia. There is inflammation in all over the body. We know that diabetes is a chronic inflammatory condition. There is an element of endothelial dysfunction and ischemia. Sodium and water retention adds to this burden, and all this leads to endocrine activation and activation of the renin-angiotensin system. So it's not only glucose that gets abnormal, it's the cell metabolism along with the neurohormonal inflammation that sets in the body. And that is why a kidney has the smallest vessels in the body and the heart is the largest vessel in the body. So right from the smallest vessel to the largest vessel, everything is hampered in diabetes. So that is why we see that most of the times in diabetes, you have heart failure and CKD as a combination comorbidity. It's not like you will have heart failure without kidney presentation or kidney disease without heart failure. So I'm sure that you will relate to your patients that ज्यांना heart failure असतो त्यांना काहीतरी microalbuminuria, so they tend to have more of albumin loss in urine, and vice versa. If you have a renal patient, they usually come with features of fluid overload and heart failure. So this is a very combining sort of a comorbidity, and we see that the prevalence, suppose you take this prevalence of 463 million of diabetes, the CKD is much higher. It is 843 million. Why is it so? Because it is like a precondition before occurrence of diabetes. Most of the time, the endothelial dysfunction sets in earlier before diabetes occurs. So the volume of CKD is definitely likely to be higher. And the large vessel disease in the form of the cardiac dysfunction is around 64 million. So this is the overall morbidity, and it's a huge population. So we want some medicine which is going to help diabetes, heart failure, and kidney, all three together at one go. So you want one drug to act on everything for benefit. And that is why this whole vicious circle of heart failure worsening the kidney disease and kidney disease again worsening the heart, this can be halted by one single agent is what we are searching for. And this search actually has been benefited by SGLT2 inventions. So you see that 24% of patients with type 2 diabetes have heart failure as their first complication. 58% of type 2 diabetes will eventually land up with CKD. Now, 58% is nearly half of your diabetic population. So if you're dealing with, say, 100 diabetic patients a day, 50 of your patients are likely to have this problem in coming future, and at least 25 will land up with some or the other cardiac event. Now, cardiorenal disease is most frequent comorbidity, and this has been proven worldwide also. Now, this has been done in a large study. It's been more than 1.5 lakh population, and this has been a population who initially was free of cardiovascular renal disease, and over a period of nearly 4.5 years. So you see that this type 2 diabetes population eventually followed over 4.5 years. Of this, 18% of this total population developed the cardiorenal disease as the first manifestation. Now, what are the cardiac diseases which comes earliest? So earliest is heart failure, followed by coronary artery disease, and peripheral artery disease, myocardial infarction, stroke come later in the line. So nevertheless, all these are the cardiovascular disease, and cardiorenal forms a chunk of this. So this is the CKD component, this is the heart failure component. And this also has a ischemic component to it, though it is not frank myocardial infarction. So compared with comorbidity-free patients with type 2 diabetes, cardiorenal patients are at higher risk of mortality, higher risk of stroke, peripheral artery disease, and myocardial infarction by themselves. So they may not have these problems, but still land up with excessive mortality. So what is the prevalence of CKD per se then? So how do you identify CKD is the first question. And second question is, how many actually of us really do the EGFR and USCR regularly? So urinary albumin creatinine ratio and EGFR forms the standard basis of doing the analysis for renal dysfunction. Now, one thing I would like to tell all of you at this forum is that the methodology of doing these tests matter a lot in interpretation. So I've seen that quite a few EGFRs are significantly low, and then you repeat it on a proper systematic day and a proper good lab, and it's absolutely normal. So whenever you're interpreting this test, be sure that it's been done with a good quality control. The patient has been resting, there has been no fever, there has been no medication, dehydration, and many other things which are prerequisites for those labs. But if you take these two parameters in account, EGFR and USCR, these are important parameters to tell us what is going wrong with the kidney. And if you take that this EGFR abnormality is seen around in 10% of diabetics, and USCR abnormalities in nearly 20% of diabetes, this is the NANES data. But Indian data shows that nearly 50% of patients would have albuminuria even at the time of diagnosis. So some patients would have both, and 60% would have none, but nevertheless 40% of this population. So you can see this graph, at least stage 1 CKD, that is presence of microalbuminuria, would be seen in somewhere around 40%, followed by the later stages, stage 2, stage 3. And this is a huge figure. It's a huge morbidity. So you see that most of the diabetics die due to 2 reasons. Either it is a cardiac disease or it's a renal disease. So you'll never hear of deaths occurring due to some other causes beyond this, especially when we consider the long-term stable diabetic patients. So you may have acute hypoglycemic deaths and you may have cancer deaths, but nevertheless, these two are the commonest comorbidities. So cardiac function can be compromised early after the diagnosis. Now, this has been proven in various studies, and there has been studies where they've shown that 68% of patients who have type 2 diabetes for 5 years have shown signs of ischemia. Now, ischemia may not be frank ischemia. It may come as diastolic dysfunction, systolic dysfunction, or both. So you see that I used to actually, when I was a resident, and even in my early days of practice, when I saw the echo report of LV diastolic dysfunction, I thought, okay, it was something like I used to look at fatty liver report. So it was that very casual. But nowadays, with the knowledge that we have with respect to heart failure and cardiac disease, we have started looking at these reports very seriously, and LV diastolic dysfunction is the earliest marker actually in the echo report, which can tell you that this patient is harboring asymptomatic left ventricular dysfunction, and diabetic cardiomyopathy may be setting in for this patient. And if you see, only 32% of the actual patients have a real normal, so-called normal cardiac function in their cases. Now, if you see what drugs are known to prevent kidney progression, so kidney worsening, the ramipril and ACE inhibitors have shown in various studies that they are nephroprotective. So they protect the kidney from worsening, especially. So all our diabetic patients, whether they are hypertensive or not, usually get either a ACE inhibitor or a ARB, because both these drugs have been proven to show that they benefit the USCR, they benefit the EGFR, and they help in prevention of progression of kidney disease. Through various studies, this has been proven. So all your patients with diabetes who have microalbuminuria or low EGFR, they should be on at least the smallest dose of ARB or ACE inhibitor. There has been studies with the combination of ACE-ARBs and direct renin inhibitors and glycosaminoglycan drugs and anti-inflammatory, but they have not proven its benefit as far as the kidney protection is considered, and they are not trained to the recommendations because of that. So one thing is definite, that aspirin is known to benefit, ramipril is known to benefit, ARBs are known to benefit. So what else is known to benefit is what we are going to discuss. So SGLT2 inhibition has beneficial effects on the kidney. How does it have? We know that SGLT2 inhibitor, that is the dapagliflozin, it acts on the SGLT2 receptors on this tubule over here. And this mainly in this particular area where there is, you can say, blocking of this receptor, what happens is it inhibits the proximal glucose resorption. It blocks the sodium resorption. It increases the delivery of sodium to the macula densa, and TGF, that is the glomerular filtration pressure, is restored. So it actually helps in reducing this pressure. We know that high glomerular pressure is one of the toxic elements to cause nephropathy. So it is going to cause glycosuria, it's going to cause natriuresis, it is going to decrease the blood pressure in the glomerulus, and in addition, it is going to decrease the urinary albumin excretion. And in this bargain, it is going to decrease the preload on the heart, and it's going to improve the delivery of oxygen to various organs. So you can see that all these beneficial effects of SGLT2 are mediated through sugar loss, water loss, salt loss, and effectively fat loss. So this is all caloric loss. So caloric loss in the body will give rise to visceral fat loss. Now, whenever all these reduce, so when the water reduces, when the glucose reduces, the preload reduces, the heart functions better. When the heart functions better, the kidney function also gradually improves. So all these are vicious effects which are beneficial. So they will improve cardiac function, renal function, improve heart failure, and improve the occurrence of albuminuria. It will also improve the blood pressure and hemodynamics in the circulation. So effectively, SGLT2 inhibitors acts through various mechanisms to various organs in the body to offer cardiorenal protection. So what about prevention then? So if the patient doesn't have kidney disease, does it protect? So this DECLARE study was done to see, this was mainly in patients without the atherosclerotic cardiovascular disease with predominantly preserved renal function. So these were mainly diabetic patients, and these patients were more than 55 years and 60 years, and they had high risk factors, and they had, some patients also had established cardiovascular disease. You can see that 60% were just having risk factors. They were not having any present cardiovascular disease. So established cardiovascular disease was not there in a larger population. So the eGFR of this population was 85. So you can actually put them into stage 1 kidney disease also, and a microalbuminuria to the tune of 30. So it is a classic type 2 diabetic patient who is diagnosed newly, which we see in our practice, that he has not yet started worsening of creatinine. One thing I would like to mention here is that don't bank on creatinine and urea to be abnormal for diagnosis of nephropathy. So nephropathy has to be based on the calculations of your lab and what they report, and based on the clinical signs and symptomatology with the duration of diabetes. So what did DECLARE show? That use of dapagliflozin in these patients with preserved renal function, even in these patients, there was a sustained decrease in eGFR, the reduction, the more than 40% reduction, decrease in eGFR was prevented. And in these patients, you can say that the decrease in eGFR actually was, the eGFR fall was prevented by the use of dapagliflozin. So nearly 47% risk reduction. So you can see that the hazard ratio was 0.53, which meant that dapagliflozin, if you give 100 patients dapagliflozin, 47% of those 100, 47 of the 100 patients would benefit for reduction in the kidney related progression. So they would decrease their level of progression of kidney disease if they were offered dapagliflozin. This is what the graph translates. And this was seen in across the spectrum. So wherever the patient had microalbuminuria, they went back to normoalbuminuria. When they had macro, they went to normo or micro. When they had macro, they went to normo, micro, or they came down to normo also. And where they had micro, macro, they landed up in normo. So you can see that one grade lower when they were using dapagliflozin. So this was the benefit that the drug was offering. The data was statistically highly significant. And this is what matters to me as a diabetologist, that I'm able to protect the kidney of the patient whom I know is likely to have renal morbidity at an early stage in diabetes. Similarly, deterioration from baseline. So deterioration from going from normo to micro or macro, normo to even the further stages of macroalbuminuria, was worse in the placebo arm. So you can see that all these forest plots show that in the placebo, there was much more deterioration than in the dapagliflozin arm. So one needs to understand that whenever you have whatever degree of albuminuria, even if you have a normal albuminuria, there is a high chance that you will prevent deterioration of the kidney function in such patients. Now, what about the composite endpoints? So composite means a combination. So combination of renal death. We know that dialysis related death or end stage renal disease is an important cause for the terminal morbidity in diabetic patients. So does it really, we saw albuminuria, but does it translate into death reduction? Yes. So this is one thing which is very important, that all the renal deaths and cardiovascular deaths were protected in these patients. So you see that EGFR decrease, end-stage renal disease, renal death, all were lower in the dapagliflozin arm, and end-stage renal disease related with death and with the composite of death per se of any cause. The composite was much, much better. You can see nearly 60% reduction in the risk of death. I think that's a huge thing that the drug achieves, and that is why we are talking so much on it, is because this is a drug which has shown that over and above the ramipril, the sartans, the ACE inhibitors, and the aspirin and the statins, we have something new to add to our patients to prevent the mortality. So this was in diabetic patient. What about those who didn't have diabetes? So if you don't have diabetes, can you really prevent kidney disease in patients? So we have a lot of hypertensive patients or patients who don't have diabetes but have dyslipidemia, renal disease, and are we able to protect their kidney? Is the second study, the DAPA-CKD, which Dr. Erendis sir was speaking. So the objective here was to see whether DAPA reduce the risk of renal and cardiovascular event in those with or without type 2 diabetes and with the maximum tolerable dose. So here they had included patients more than 18 years with a EGFR between 25 to 75. Now this is very interesting that EGFR as low as 30 also were into this arm, and the urine albumin excretion as high as 5,000 were included into this. So 200 to 5,000. So nephrotic range proteinuria were also included in this. And they were already on ACE and ARBs with or without diabetes were the criteria. So you had some patients who didn't have diabetes. And what they saw in this was they tried and studied what happens to the EGFR over time and what happens to the renal and cardiovascular death and what happened to the total all-cause mortality related to the use of this thing. The follow-up of this patient was for 3 years, 2.5 years. So 2.5 is within 2.5 years, how much did the drug benefit is what was studied. And you can see this p-value is huge, the very, very, very significant, very significant. What it tells you is that dapagliflozin significantly slowed down the decline of renal function. So you can see that this drug reduction, for that matter, is reducing the risk by nearly 40%. And this significance of this drug, as far as the renal protection was considered, was a very significant figure. You can see the NNT is number needed to treat, was just 19. So every 19 patients, it saved one renal composite or renal dysfunction. That is what it shows. So every 20 patients, you will save one patient's kidney when you give this drug. All individual components, if you have to see the benefit in this patient, everywhere dapagliflozin scored over the placebo. Now, of course, placebo here is only in comparison with DAPA placebo, but they were on ARBs and ACE inhibitors. So it tells us that addition of this drug beyond ARBs and ACE inhibitors is a beneficial component, and the worsening of end-stage kidney disease, more than 50% decline in EGFR, and even for that matter, the cardiovascular death and renal death was lower in this population. And protecting from death, I think, is what we aim in diabetes long-term management. Now, treatment benefit was across the spectrum of all the groups. So whether they had type 2 diabetes at baseline, whether they were non-diabetic, whether they had urine albumin less than 1,000, more than 1,000, EGFR less than 45, more than 45. The stage of kidney disease was 2, 3, or 4. So wherever you use this drug in these trials, there was a significant benefit. But if you can see that the dots are more on the left side with the earlier stages. When there was no diabetes, the benefit was better. When there was less albuminuria, the benefit was better. When the age was more than 45, the benefit was better. And early stage of kidney disease, the benefit was better. So earlier you use, the better you'll get the benefit. And even you don't wait for the patient to develop albuminuria. You are actually using it much, much prior to protect the kidney. So this has been proven across all the trials, and especially death and hospitalization for heart failure has reduced significantly even in this study. And this was true even in the non-diabetic patients. So 30% reduction in the relative risk of hospitalization, and absolute risk reduction of nearly 2%. So this was a significant reduction in hospitalization rates. Even for that matter, the dialysis requirements were much less. Even dialysis related deaths were much less. And you can see that the risk reduction for hospitalization of death from any cause was nearly around 31%, which is very significantly low. So it tells me that when I use the drug, the chances of the patient getting hospitalized for heart failure, for kidney disease, or for dialysis is much lesser. And if you see this overall mortality was 4% versus 6.8%. So 2% lesser in the DAPA arm versus the placebo. And this was statistically very significant. So we need to know that these statistical figures are very important to us in clinical practice, and they make a lot of difference to the quality of life of our patients. Now coming to the adverse event and the safety profile, and we know that the genitourinary side effects are the known side effects. So we need to be judicious, especially when we are talking about renal safety. So if you have patients with repeated pyelonephritis, repeated UTIs, repeated genital infections, please don't think of kidney protection there and use the drug, because the chances that you'll worsen the side effect is very high. So it is better that you identify your renal patients properly and then you think of using this. But nevertheless, in the study, the discontinuation rate was not very high because these are controlled population. The discontinuation due to adverse events also was not high. It was at par with the placebo. Any serious adverse event, in fact, was lesser in the dapagliflozin arm. And most of the serious events were hospitalizations, which were lesser in the DAPA arm. The fear of amputation and fracture were not seen in this particular study, which were reported with canagliflozin, and major hypoglycemia, volume depletion, and renal events were not significantly higher. Of course, here you need to have 2-3 important things which you need to monitor clinically. One is, as I said, signs and symptoms of urine tract infection. You need to see for the patient's volume depletion. You need to tell especially the elderly, you need to drink large amounts of water, especially in summer, because you can precipitate euglycemic ketoacidosis, though it was not seen in this population over here. And Fournier's gangrene is a risk reported with canagliflozin, but not seen with dapagliflozin. So you can see that dapagliflozin helps from prevention to treatment across the spectrum of renal disease in patients with or without type 2 diabetes. And they have been studied in a huge population, huge normal population in the tune of nearly 4,000 and 17,000 patients with different varying degrees of USCR from 13 to 949, and you can see eGFR ranges between 85 to 43, and there has been improvement in the outcomes in the form of renal progression, cardiovascular disease, heart failure, hospitalization, and all-cause mortality in all categories of patients, whether they were normal, whether they were diabetic. So if you have patients with high renal risk or high risk of renal disease, it is better to use these molecules as a protective agent. And safety was proven across the spectrum with no major signals, especially which were reported with other SGLT2 inhibitors. So that is why guidelines have now come up with specific categories saying that if you have a patient with atherosclerotic cardiovascular disease or CKD or heart failure, you prefer using SGLT2 with proven cardiac benefit, proven renal benefit, which prevents progression, and heart failure related benefit with SGLT2. So you see 1, 2, and 3, all these 3 categories, the benefit of SGLT2 inhibitors is across the spectrum. So this dapagliflozin, canagliflozin, and Empar are available in the market, and of which DAPA has been studied extensively in terms of heart failure outcome, renal outcome, and progression in cardiovascular outcome trials. And I think now it's more used by cardiologists than by diabetologists. That's what I've known of. But nevertheless, I don't see that day far off when nephrologists will use it much more and physicians will use it much more. So to summarize, the prevalence and global burden of CKD is substantial, and DAPA-CKD has proven that it is known to be a renoprotective agent. DAPA-CKD builds on the evidence offered by DAPA, the DECLARE study and the DAPA heart failure study, to extend the cardiorenal benefit of dapagliflozin in these patients. So I thank you all for the patient listening, and thank you IMA for inviting me here. Thanks a lot.
Thank you very much, madam. Very nice lecture you have taken, and it's a very difficult task to tell all the reactions and all the effects of the dapagliflozin. But you have made it very simple. So very nice, and thank you, madam. And now our President, Madam Dr. Meenakshi Deshpande has come. So I will request her to give you.
Thank you.
And
Thank you. Dr. Vaishali Deshmukh, I think you are so much associated with IMA. Now you have become a very close friend
I know,
of IMA
know.
Pune.
Yeah,
So thank you very much, Dr. Vaishali. Yeah.
Thanks
This
a
is
lot.
a bouquet for you and IMA Uparna, which we have already met and given you at UConn also. So,
Yes. It's a sense of pride to us to be in the IMA event. Thank you so much.
Thank you.
thank you, madam. Thank you.
I think there are any questions in the chat box. Yes.
Yeah, 1 minute. I think just now somebody has put the last question. What to do? No, it's over, madam. 1 minute.
Okay,
I
it's
think,
over. Okay.
Yeah, one question. No, he has written his IMMC number. What is the incidence of euglycemic ketoacidosis with dapagliflozin in elderly newly started on it in your experience, madam?
Yeah, I have seen one patient who has come with euglycemic ketoacidosis, and actually she was not an elderly patient. She was 45 years, but she had extensive travel in summer. She was on SGLT2 inhibitor and she was well controlled, but she landed up with symptoms of ketoacidosis and dehydrated because she could not get access to water during her journey. And so in elderly also, we might have the same situation. It has been reported in elderly. So how does euglycemic ketoacidosis present? It comes same like a diabetic ketoacidosis, except that the sugar is normal. So whenever you have a patient presenting with dehydration or the patient is diabetic and telling you that the patient is having a coated tongue and there is urinary ketones which are positive and your sugar is 110 or 120 and 150, you suspect euglycemic ketoacidosis, you do a ABG, especially if the patient is on SGLT2 inhibitor, and you stop that, you treat it like a diabetic ketoacidosis. So you give fluids, you give IV insulin, and these are patients whom you need to use SGLT2 inhibitors very cautiously because they have a metabolic defect in their oxidation, and that is why they have landed up with ketoacidosis. So I think you need to have caution here. I hope that answers the question.
Yes, thank you, madam. Dr. Padma Iyer, do you want to say something? Dr. Padma Iyer, madam?
No, Alka. Madam said.
Yeah. Okay, madam. Thank you.
Thank you so much. Thanks a lot.
Thank you so much. Yeah, thank you. So now we are coming to the last lecture. Dr. Rewale sir, Jaideep Rewale sir.
Ma'am, he's joining in 1 minute. Just
Okay. So we'll wait. Okay.
Yes, madam. Renal sir has joined.
Yes, 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 yes. Good afternoon and welcome, sir. Sir, have you joined? Dr. Rewale, sir. Yeah, unmute yourself.
Yeah, hello, madam. Sujit here. I'm from
Yes, you can
AstraZeneca.
check your presentation, sir.
Yeah, hello, I'm Sujit here. I'm from
Yes.
AstraZeneca. I'm just following with Dr. Devle, sir. He will join soon.
Okay, okay,
Yeah.
okay, okay.
Yeah,
Yeah,
I will
he'll be
just change
joining.
my.
I thought
Yes.
he had joined because his name is come.
Yes,
So-
yes.
So all the delegates, it was a very nice academic feast. This is the last lecture by Dr. Jaideep Rewale. He's joining in a minute or two. So by the time if you want to ask any question, Dr. Rajiv Sethi sir is also there, and you can ask him questions, because today we are very fortunate to have very eminent speakers, and they are Dr. Jagdish Hiremet sir, Dr. Rajiv Sethi, and they are still online. Dr. Suhas Erande, Dr. Vaishali Deshmukh, she has just completed her talk, and now Dr. Jaideep Rewale, we are waiting for him to join.
Yeah, hello, sir. Welcome.
Yes,
Yes.
sir. Good afternoon and welcome, sir.
Good afternoon, ma'am. Thank you.
Yeah, good afternoon.
कशा आहात?
Sir, छान आहे. Dr. Meenakshi Deshpande, our president, is there.
Hello.
And I am Dr. Alka Kshirsagar, secretary.
Namaste, madam.
Namaskar, sir.
Namaskar.
Sir, can we start? Do you want to check
Yes,
your slideshow?
I will share my slide.
Yeah, you can.
Give
Please.
me 1 second.
By the time I'll start introducing you, if you don't mind, or I'll
No
wait.
issue, ma'am. Yes.
Okay, sir. Okay, sir. Sir will be speaking, Dr. Jaideep Rewale will be speaking on trump card in management of diabetes and its complications throughout the spectrum. And I will introduce sir. He's a MBBS, a fellowship in diabetology with gold medal. He's a chairman and consultant diabetologist. Dr. Rewale is diabetes and nutrition care and research center at Satara. District's first center dedicated to diabetes care since 2008. Sir, great. Founder and director, DNA, Diabetes and Nutrition Awareness Academy, co-founder, PH Shopee, it is Premium Healthy Food Store, organizing secretary, DCC 2018, areas of interest, diabetes, food, and social awareness. And he has received Diabetes Awareness Initiative Award for 2016 from Maharashtra State at World Congress of Diabetes 2017. He has delivered more than 400 lectures to various organizations and conferences. So, to you, sir. You can start, sir.
Yes. Thank you. Thank you, madam, for the kind words, and thank you, IMA Pune, for giving me this opportunity. Slides are visible?
Yes, sir.
Yes, and
You can move the slides and just you can check so that there will be no. Yeah. Yes, sir. Yes, sir. No problem.
Okay, great.
You can.
So thank you everyone, and thank you Astra for giving me this opportunity, and thank you everyone for being part of this academic activity. So let's start with this interesting slide. This is a 47-year-old male patient recently diagnosed with a type 2 diabetes without any complication. So in these slides, basically they are trying to show how the cardiorenal metabolic risk continuum flows. From the minimal risk factors to the increased risk factors of the heart failure, then there will be some events in terms of the cardio and renal events, and then patient ultimately will land into the complication. So this, our patient is basically in a part 1 of this continuum. Now, because he's recently diagnosed, we need a better glycemic control for this patient. But what the data says from the India, that only 33% of diabetic population is having the HbA1c of less than 7%, which is defined by the target by the ADA. So unfortunately, 67% patients in India are still not under good control. Now, here is the opportunity by using SGLT2 inhibition, and these are some potential clinical benefits. It reduces the blood glucose. That's how it reduces the microvascular morbidity, decrease glucotoxicity, and they have the low risk of the hypoglycemia. Now, the action of the SGLT2 inhibition through which mechanism they reduces the glucose is basically insulin independent. So that's why they can work at all stages of the diabetes, and patient will have the osmotic diuresis because of the SGLT2 inhibition, and that's how they have the weight loss and reduction in the blood pressure. And again, the loss of excessive glucose in the urine basically turns into the negative caloric balance for this patient, leading to the reduction in the weight. Now, these are the multiple glycemic and extra glycemic benefits with the dapagliflozin. You can see across all the ranges of the HbA1c from 7.9 to 9.4, dapagliflozin is able to reduce the HbA1c between 0.8 to 1.3% at the end of the 24 weeks. When we see on the right side, along with the metformin or as a monotherapy with the sulfonylurea, add on to the DP4 inhibitor, dapagliflozin does a better job by the reduction of the HbA1c of approximately 0.8%. Now, coming to the weight loss, more the weight at the baseline for the patient, we get the better weight loss. So with the higher BMI, almost 3.5 kg of weight reduction can be achieved. And there is definitely reduction in the systolic as well as some diastolic blood pressure reduction has been achieved with the dapagliflozin because of the osmotic diuresis. Now, this is a $1 million question that most of the anti-diabetic therapies do fail over a period of time. So what therapies we should use which will give us the consistent result in terms of the better glycemic control? So here is the answer, that dapagliflozin gives the proven 4-year sustainable control when they are compared with the glipizide. On the left side we can see. Then in terms of the body weight reduction, that was also sustained over a period of time when they are compared with the glipizide and metformin. The same thing with the blood pressure reduction with the Forxiga or the dapagliflozin. The blood pressure reduction was fairly well reduced and it is preserved over a period of time. And most importantly, all these effects were without any significant increase in the risk of the hypoglycemia. So this is very, very important that you get a better HbA1c control, better blood pressure reduction, you get a better weight loss, but without increase in the risk of hypoglycemia. From the clinician's point of view, this is very important aspect of any drug. Now, this is a very busy slide. I would not will not go into the details of this diversity CVR trial. So let's go to the case 2, who is a 52-year-old patient diagnosed 5 years ago, but he has some increased risk, and that's why he is in a next level, that is the part 2 of the cardiorenal metabolic continuum risk. So let's try to explore what are the options. So now, window of opportunity for the cardiorenal prevention in this particular patient is the stage of left ventricular dysfunction and new onset of the albuminuria, specifically microalbuminuria. Now let's try to understand the left ventricular dysfunctions and the heart failure. These are often undetected complications of the type 2 diabetes patient, and it is nearly forgotten complication. And if you look at this particular graph, almost we can see 68% patients had evidence of the asymptomatic left ventricular dysfunction when they are diagnosed of a type 2 diabetes for the 5 years. And again, the undiagnosed heart failure was detected in 48% cases. So left ventricular dysfunction and the heart failure, these are the two risk factors or the complications which often are undetected in routine clinical practice. Now, microalbuminuria is very, very important factor from the renal point of view, but it is equally important to understand that the increase in the microalbumin excretion is a risk factor for the cardiovascular disease. Now, how do we place a DAPA in this case, providing the window of opportunity? Now, if you look at the most of the trials which have been done, CVOT trials till date, these are the typical 4 quadrants, and on the left side where the red square is there, that is the declared TIMI and Carolina and Rewind trial. This particular square represents a typical primary care type 2 diabetes patient set, and that's why these trials like a declared TIMI, Carolina and Rewind trial have a very important message to carry for the clinicians, because they deal with the patients in day-to-day life. So these are the representative population of the day-to-day clinical patients. So declared TIMI 58 trial with the DAPA represent the patients in a typical primary setting that we see in a daily practice, where the primary prevention of the cardiorenal complication is the key. So let's try to understand what declared TIMI actually trying to tell. Now, this is the population of the declared TIMI trial. So 59% patients having the multiple risk factors, but they don't have the prior ASCVD. So the primary prevention was the target. And 40% patients who were enrolled into the declared TIMI where either had a prior myocardial infarction or they had ASCVD but no prior myocardial infarction. So this typically represent the population which we see in our clinical practice. Now, what happened in declared TIMI? We get good reduction in the MACE in all the populations who are at the risk, and we get the CVD and hospitalization for the heart failure benefits for almost all the patients, and there are renal benefits for all the patients. So now when we try to analyze these patients, that almost 60% patients in these trials were not having prior ASCVD, but they are having multiple risk, or they were having multiple risk factors, and they were the target population for the prevention of the ASCVD, which is a typical case in our clinical practice. And declared TIMI has clearly shown a benefit of the dapagliflozin in terms of the cardiovascular morbidity and mortality, hospitalization for the heart failure, reversal of the macroalbuminuria to microalbuminuria, from the microalbuminuria to the normal albumin excretion, so, and prevention of the new onset of the microal. So this is very important for us. Now, declared TIMI confirms the well-established safety profile of the DAPA. So more than 17,000 patients has been extensively studied for more than 4 years, and you can see there are acceptable side effects or adverse event profile which is seen in declared trials. So drug is relatively safe and very comfortable to use in a clinical practice. So the story so far is the management of the blood glucose, avoidance of the obesity, treatment of comorbidities like obesity and hypertension is equally important. So we have to shift our focus from the glucocentric to the looking at the other possible parameters for the management. Use of the SGLT2 with the caution in the third and fourth line agent, which was the position statement of AD and AAC in 2013. So in 2013, this class of the drug has been positioned at the fourth or the third line. Now, if the ASCVD, HF and CKD predominates, SGLT2 inhibitor use can be done after the metformin that has came in a picture in 2018. So from 2013 to 2018, SGLT2 has gone up from the third position or the fourth position to the second position. So now what guidelines say currently after 2018, what has changed? Now the change is now consider the independent of the baseline HbA1c. The SGLT2 inhibitor should be considered as a first line of therapy, irrespective of the baseline HbA1c, if there is established ASCVD or there is an indication of the high ASCVD risk, or the patients with the heart failure or patient with the CKD. These are the first line therapy that has been come in a guideline in 2020. So from 2013, position 3 or 4 to 2018, position 2nd, and now in 2022, SGLT2 are at the position number 1 as a strong recommendation by the most of the guidelines like AD, AAC, that they should be used in a patients with established cardiovascular disease, or the patients with the heart failure, or a patient with the CKD, irrespective of their HbA1c control. This is very, very important to understand that irrespective of their HbA1c control, this class of the drug has been advised to this particular class because of their benefit in terms of the cardiovascular risk reduction, reduction in the hospitalization for the heart failure, and the renal benefit. Now, these are the some evidence with the different SGLT2 inhibitors, because there are n number of SGLT2 inhibitors in the market. So DAPA is having a strong data in terms of the reduction in the heart failure, CKD progression. Then the primary renal outcome data is very strong with the DAPA, and the primary heart failure outcome is also very, very strong with the DAPA. So if you ask me which is the best choice of the drug among all the SGLT2 inhibitors, definitely I will go with the dapagliflozin. Now, then part 4 and part 5, we know that there are already events has happened with the patient, and patient is already into the complication. Now we need to reduce the morbidity and mortality in this particular set of the patient. So this is the heart failure is a very big problem. It is a global picture. I hope that previous eminent speakers must have talked on this, so I will not waste my time to explore the prevalence of the heart failure. But to just give a picture that at least 8 to 10 million patients with the heart failure are there in India. Again, coming to the CKD, CKD is also globally very prevalent, and the global prevalence of the CKD is 698 million cases. The global prevalence of the CKD is over 19 million. So the problem with the CKD and the heart failure is very, very big. So now what are the therapeutic options or the innovations to prevent the new onset or the worsening of the renal function has been advised. So till date, if you look at the particular drug, so recently, if you look in this data, there are a few drugs which has been added in 2013 and 2012. However, in terms of the effect in the CKD progression, it's not seen with the aliskiren or the glucosamine glycans or some anti-inflammatory drug. They failed to prove their effect on the CKD progression arrest. Now, what is the proven? Again, the old drugs are still remain in the market, and old is gold. So ACE inhibitors like ramipril and ARBs like irbesartan, losartan, and olmesartan are still there, and they have been proven in terms of the arrest of the progression of the CKD. Now, coming to the DAPA-HF trial. So now this is the first and the largest SGLT2 heart failure reserve ejection fraction trial to successfully improve the outcome and the symptoms in the patients with the heart failure. So the DAPA-HF basically enrolled more than 4,700 plus patients, and they were divided into two groups. Now, 45% patients in this particular trial had a type 2 diabetes, and 55% patients were non-diabetic. So this is very important that these patients, almost 55% patients were not having diabetes. So the effect of this particular drug in a non-diabetic patient can be seen in this particular trial. Now, there is a significant reduction in the composite of the CV death or the worsening of the heart failure, with 26% relative risk reduction with the hazard ratio of 0.74, and it was statistically significant. Now, the consistent benefit across the board and representative of the population, because we have seen that the population enrolled into the DAPA-HF is diabetic and non-diabetic also. So it actually represents the population what we see in day-to-day clinical practice. So most of the patient had a background heart failure therapy, they were on the diuretic use, and they have the baseline left ventricular ejection fraction, and the NT-proBNP levels were monitored, EGFR was monitored, and there was a reduction in the risk of both first and recurrent hospitalization for the heart failure, reduction in the all-cause mortality, which was statistically significant, improvement in the symptoms of the heart failure, and a significant reduction in the risk of the CV death and worsening of the heart failure has been documented as early as 28th day of the starting of the treatment. So that was something amazing. You start the drug, and within 1 month, you are able to reduce the risk of the cardiovascular death or the worsening of the heart failure. So that was the power with the DAPA-HF trial. Now, in terms of the safety, it was well tolerated and the adverse events rarely lead to the discontinuation of the therapy. So from the tolerability point of view, dapagliflozin is very, very good. Now, this is a comparison of the endpoints in the two trials of the SGLT2 for the hospitalization for the heart failure. You can see that there is a Emperor trial also, and we have the DAPA-HF trial also. But when you compare, still DAPA-HF gives a robust reduction in terms of the all primary endpoints. Now, new expert proposal for the sequencing of the hospitalization for the heart failure reserve ejection fraction foundation therapy, they have advised that the first step, that is the simultaneous initiation of the beta blocker plus SGLT2 inhibitor. So SGLT2 inhibitor has come in the picture as a first line of therapy in a patient with the established heart failure. And early goes into the second stage, and MRA, that is mineralocorticoid receptor antagonist, goes into the third step. So SGLT2 inhibitors here also in a patient with the heart failure stands as a first line therapy along with the beta blocker. Now coming to the DAPA-CKD, now if you look at the renal point of view, there is a 44% relative risk reduction in a composite outcome of the sustained GFR more than 50%, 29% relative risk reduction in a CV death or the hospitalization for the heart failure with the hazard ratio of 0.7%, and there is 31% risk reduction in terms of reduction in the any cause mortality. So this trial was basically stopped early due to the overwhelming efficacy. So results were consistent in patient with or without type 2 diabetes. First renal outcome study to show the robust benefit on all-cause mortality and hospitalization for the heart failure and the CV benefits in the CKD patient that was consistent with the DAPA-HF, and with the declared demonstrate the ability to and prevent to treat cardiorenal complication across the spectrum. So now the 2022 KDIGO treatment algorithm for the patient with the type 2 and CKD. So this algorithm basically was designed for the patients who are having the chronic renal disease. Physical activity, nutrition, and the weight loss, again, these are the pillars, and the metformin can be used up to the GFR 45, but the dose has to be reduced. If the patient is having stable renal function, metformin can be continued up to GFR of 45. Anything GFR between less than 30, the metformin should be discontinued. With the patients with the GFR less than 30, it is advisable to stop SGLT2 inhibitor. So it cannot be continued. On the patients on the dialysis, definitely we don't use most of the time oral medications. Definitely we can think of GLP-1 RA, but again, because of patients with the CKD already has nausea, vomiting, loss of appetite because of uremia, so GLP-1 RA are not well tolerated. The preferred drug to use in this class of patient is insulin. Now, dapagliflozin now covers the entire spectrum of the cardiorenal continuum. So we have the declared trial, we have the DAPA-HF and DAPA-CKD. We have seen all these trials. We have seen there is a primary endpoint and the secondary endpoint reduction. So basically, dapagliflozin covers all the aspects of the cardiorenal continuum. Now, there is a novel evidence with the DAPA that it reduces the liver and pancreatic fat. So DAPA improves the body fat pertaining and the hepatic and pancreatic fat in type 2 diabetes patients in the North India. So this is a patient from, this is a paper from India by Dr. Anup Mishra and group. And there are several outcomes, but again, I'll be a bit skeptical on this study that we need more robust studies to document or to conclude that it actually reduces the hepatic or the pancreatic fat. Now, last couple of slides that how we can ensure the better efficacy and outcome, that we need to choose innovator or we need to go for some generic version. Now, what does evidence suggest? That evidence suggests that the pharmaceutical equivalence is not equal to bioequivalence and is not equal to therapeutic equivalence. So this is very complicated to understand what this means because this is some pharmacological terminologies. So there are some stereoisomers, and a simple structural difference in a chemical structure can hamper the bioavailability and the PKPD of particular drug. So chirality essentially means the mirror image and not a superimposable molecule. To say that the molecule is chiral, it is to say that it's a mirror image, is not the same as itself. So this is very confusing statement. So let's try to understand what they want to say. So dapagliflozin is a chiral molecule with the 5 stereogenic centers. So these are the 5 stereogenic centers. Now, having the right stereogenic center is a key for appropriate bioavailability, rate of metabolism, metabolites, excretion, potency, and selectivity of the receptor transport, enzyme, and the toxicity. So ultimately, all PKPD is revolving around the right stereogenic centers in a particular molecule. So if there is any change in this stereogenic structure of the molecule, which usually happens when we use the generic versions of the drug or the biosimilar, because they are not innovators, so there might be some changes in these stereogenic centers which can affect their bioavailability, which can affect their binding to the receptor site. It can affect the excretion, or it may have some metabolites which can cause the adverse effect, and some unexpected adverse effect can be seen. So the point to take home that the DAPA is one of the best molecule to use when in our day-to-day clinical practice, where we want to prevent our patient to land into the renal metabolic continuum. We want to arrest that complication progress. This is the best molecule which with the best support of the evidence from the DAPA-HF, DECLARE-TIMI, and DAPA-CKD trial, which covers all the aspects of the cardiorenal continuum with robust HbA1c reduction, either you use with the metformin or you use with the other sulfonylureas, better HbA1c control, less risk of the minimum risk of the hypoglycemia, robust weight loss between 1.2 kg to 3.5 kg. You will get a better control in the blood pressure. And there are some papers which are saying that it will reduce the hepatic and the pancreatic fat. So this was the conclusion about the dapagliflozin and its use in a cardiorenal continuum, and the use of the originator molecule will definitely help to achieve this target with a good bioavailability and reduce adverse effect. With this, I thank you all of you for your patience listening. Thank you IMA Pune for giving me this opportunity on this very excellent academic platform. And I thank AstraZeneca for giving me this opportunity. Thank you very much. If there are any questions, I'll be happy to answer. Hello.
Hello, Pankaj here, sir. Just wait a minute, sir. I'm making a call to IMA. Just 1 minute, sir. I think some technical issues are there.
Okay. Okay.
Hello, sorry for the interruption. We had out of the online procedure.
No
so
issue.
thank you very much, sir. It was a very wonderful lecture and you have elaborated very nicely. So thank you very much. We'll see if there are any questions. I don't think so. So
There is, I think,
please,
one
we'll-
question. If dapagliflozin is not tolerated, what is the
Yeah,
other?
yes, sir. That was answered by the previous speaker.
Okay,
Dr.
okay, no issue. Great, great.
Madam. Yeah. So, yes.
Right.
So thank you very much, sir.
Thank you,
I
ma'am.
will request President Madam Dr. Meenakshi Deshpande to felicitate you.
Thank you very much, Dr. Revare, sir.
Thank you, ma'am.
Okay, from IMA Pune.
Yes, thank you. Thank you.
This is sir. Whenever you come to Pune, please visit IMA Pune.
Sure, ma'am, sure.
We will be there in the evening time. We are there. Otherwise, you can call us and we will be available.
Sure, ma'am. Yes.
Thank you, sir.
Thank you.
very
Almost
much.
all give us a good feedback about the series of webinars which are occurring.
Yeah, ma'am. This is very,
interesting.
IMA Pune is doing really fantastic job, and it is on a regular basis. We're having the very good panel of the speakers, and the topic has been selected
Today
very
we
nice.
had Dr. Rajiv Sethi and Dr. Jagdish Hiremat.
Yeah. Today I saw the
other two, and you are the fifth one. Dr.
Yes.
Vaishali Deshmukh and Swasana. So it was a cream on the.
yes,
you know,
ma'am.
it was
All
a
are
wonderful,
the all are legends in their own field.
Yeah.
yes, sir. Yes,
Yes,
sir.
We
ma'am.
get them on this platform of IMA Pune, so it's really good thing for us also.
Yes. I should congratulate your team actually for taking this all the efforts from the busy schedule. So congratulations to IMA team.
Question was not answered. Yes,
One
sir.
question
That
was
question
not
was
answered.
not answered. That's what she's saying. We were talking about.
Good questions are there, sir.
Yes,
Shafagupta Prathan, I think.
Yeah.
Just scroll back. What was the question?
Yeah, she had asked if dapagliflozin is not tolerated, what is the other choice?
Okay, that question has to be answered.
Yes.
Okay.
Yes, sir. This is the answer.
Okay, so first thing, what is mean by dapagliflozin is not tolerated? Whether you are getting the adverse effect because of the dapagliflozin, most common adverse effect we see that is itching at the private part, specifically in males. Patients come back with the balanitis or the cracks over the foreskin of the penis, and in a females, patients will come back to you with the itching at the private parts of the urinary tract infection. So these are the common presentations once patient put on the dapagliflozin. If this is the case, then the whole class is you cannot use. You cannot use another drug in the same class. Like you cannot stop dapagliflozin and you use another gliflozin. So because if you use that, it is a class effect. It is not pertaining to the particular dapagliflozin. So if you are getting this type of the adverse effect, and for this you are stopping the dapagliflozin, then the whole SGLT2 inhibitor class you have to stop, and you have to think about adding some other class of the drug like DP4 inhibitor, or you can add sulfonylurea, or if indicated, you can go for insulin also, or you can go for the GLP-1 RA. So I hope I answered the question.
Yes, sir. Thank you, sir.
Yes, thank you.
So with this, this was your last lecture in this today's webinar.
One more.
Sir, if loose motions is side effect.
Loose motion is not routinely seen with the dapagliflozin. That is mostly seen with the metformin. And some cases with the even DP4 inhibitor can come with the complaints of the loose motion. But again, another important thing to understand that most of our patients, diabetic patients, are on ARBs like telmisartan or olmesartan, which has a tendency to disturb gut, which is routinely we don't look from that angle, that antihypertensive causing some GI disturbances. But there are few cases that will not tolerate telmisartan or the olmesartan. So once you rule out that why the loose motions are there, then you have to look anti-diabetic also. You have to look at the prescription from the antihypertensive drugs part also. But SGLT2 inhibitor per se will not cause loose motion. Metformin is the commonest cause. Metformin or DP4 inhibitor.
Okay, sir. Sir, one more question: that is there any role of dapagliflozin in pre-diabetes?
Okay, that is
Kidney and
okay. That is $1 million question. Okay, that is $1 million question, and I think that is very interesting. That whoever is asked the question, that is very interesting question he has asked. See, in a pre-diabetes, why you want to use the dapagliflozin? That is the first question. Because the trials till date in a pre-diabetes, the lifestyle modification and the reversal of the diabetes in a pre-diabetes patient is almost 56%. Only if patient does the lifestyle modification. With any drug like voglibose or metformin, the results of the reversal of the diabetes is not more than 26%. So with the drug, if you want to use particular drug in a pre-diabetic patient for the reversal, then drug is not the ideal because the success rate is hardly 25%. If you go with the lifestyle modification, there is a clinical trial data available which shows 56% reverse patient will reverse to the normal glucose metabolism with the lifestyle. Now, the question is, if you want to use the dapagliflozin in a pre-diabetic patient, where you see that patient is having the high risk of the high cardiovascular risk, or the high patient is having the history of the heart failure, then this class of the patients can be put on the SGLT2 inhibitor, irrespective of their BSL status. So that is what the guidelines are currently saying. Irrespective of the HbA1c, you can use SGLT2 inhibitors if there is a high cardiovascular risk or the proven heart failure patients. So in these two categories, or the patients with the CKD, you need not to worry how much HbA1c is there for the patient, whether patient is pre-diabetic, diabetic or non-diabetic. You can use SGLT2 inhibitors in this class of the patient. But only for the reversal, that I will not advise, or there are no guidelines. Just for the reversal of the diabetes using SGLT2 inhibitor, that is not advisable.
Okay, thank you, sir. Okay.
Thank you, ma'am.
Okay, thank you, sir.
Thank you.
I thank all the speakers, all the delegates, and AstraZeneca for all this very fantastic academic feast to us today. So thank you very much. I think now we'll be ending with this webinar. So Mr. Deepen, you can close the link. Yes, sir.
Okay, sure.